environment.
We're over 18 months into the pandemic now, and there have been millions of cases around the world. Surely we must be in a position, given the volume of evidence that is available around the world, to be a bit clearer about which are the most important risks of transmission.
I think, again, I come back to the fact that it depends on the specific circumstances. So to give you some examples, we, as part of our national course study, have been looking at outbreaks because that's really the best available information you can get about what's going on in the real world. And we felt that getting real world data was critical in understanding exactly what was going on. And it soon became apparent that, for example, if you looked at the outbreaks in similar settings in different locations, you saw different things. So you wouldn't see, for example, the same attack rate if you looked in warehouses in the north of England versus the south of England. It varied quite significantly. So therefore, different things are going on in those work environments. And what we believe is that depending on the complex mix of issues, and that can be the mitigations that have been put in place by the work environment, the behavioural issues, the demographies, etc., you will get these differential patterns of transmission. And therefore, we can't say for definite that one route is more important than another in any one situation. What we can say is that we think the airborne route has become more important and is clearly probably, if pushed, the most critical. But I wouldn't want to say that we could rule the others out, and it would depend on, as I say, the specific circumstances of each incident that you were looking at.
Thank you. Can I ask Professor Mondelli, given your research in Italy, but also kind of looking around the world, what is your perspective on what are the principal routes of transmission and particularly the relative risk of each route?
Well, first of all, thank you for inviting me, and hello to everybody. I essentially agree with Professor Karan that airborne transmission is the most important way of transmission of COVID-19. We've done some work on the transmission through fomites and inanimate surfaces, as you probably know. And what we found was that in the real world, the probability of transmission by inanimate surfaces was really not important and probably not present. The virus was present in minute amounts, and those minute amounts were unable to transmit the infection in vitro to susceptible cells. So I believe that the transmission via fomites and inanimate surfaces is really a minor way of transmission, but we shouldn't lower the guard and keep on considering those ways of transmissions as possible, even highly improbable.
Thank you. Just before I turn to my colleague Graham Stringer, can I understand, was that based on research that you conducted or supervised in Italy, and in what settings, or is this based on an appraisal of the international literature?
No, we actually did work on the field, and specifically in ordinary infectious disease wards and dedicated emergency rooms and sub-intensive wards. So very high risk places. I must say that we did routine disinfection and cleaning procedures using chlorine once a day, and but we didn't do any cleaning on the walls regularly. So the cleaning was performed essentially on the floor. And there were several other objects that we looked at by just swabbing with a specific flock that it is currently used for nasopharyngeal swab. We use a transport media to swab all the surfaces, including computer keyboards, cell phones, consoles, infusion pumps, cupboards, gowns were worn by medical staff and nurses, and found nothing, just found some traces of virus on the CPAP helmet that was soft, and that's obviously that's what you would expect. So close to the airway of the patient, I wouldn't be surprised if we didn't find any trace of viral RNA. So it was, we did 2 studies, and the methodology was quite similar. And I want to emphasize that the differences in the experimental approach by early studies by American groups that in the lab just sprayed high concentration of virus onto surfaces like copper, steel, plastic, and cardboard. Ended up in detecting high titers of virus on those surfaces, which took several hours, if not days, to disappear. So that was an experimental setting and not a real life setting, which I think is the one we have to take into consideration.
Thank you. So the early experiments were putting very high levels of contamination
in the laboratory. Yes.
In the laboratory, but the settings in which you analysed
were real life.
Real life in hospitals where there was a significant risk of COVID, and you found that it was only in the CPAP, that's to say a kind of oxygen supply helmet.
Yes.
It was only that had an appreciable contamination.
Contamination, and despite swabbing and seeding into susceptible cells, we were not able to grow any virus from those isolates. Obviously, we didn't do any investigation out in malls or other shops or department stores. That would be another interesting setting, but I believe that the evidence that we produced shows that the common disinfection procedures are enough to avoid transmission through.
Thank you very much indeed. Thank you. That's very clear and helpful. Graham Stringer and then Carol Monaghan.
Professor Curran, my apologies. I'm going to have to leave soon after these questions. Can you tell us what protectors found to be the highest risk workplaces?
Very interesting question, and of course, again, the information has changed over the course of the pandemic, and it depends how you quantify that risk. So the early studies looked at epidemiological evidence and looked at excess mortality in certain occupations using census data from 2011. That demonstrated that there were a number of occupations which had an increased risk. But those calculations didn't correct for other potential risk factors, such as socioeconomic status or ethnicity or other various issues. We have, as again, part of the National Cause Study, done some of that analysis where we have looked again at some of those other risk factors, and we demonstrated that the association with work fell quite significantly once those risk factors were taken into account. And whilst it didn't disappear completely, it dropped by a significant amount, such that the excess risk wasn't doubled, which is one of the sort of approaches that's used to determine an excess of risk. So the early work that was done, I think, gave us an indication of where we needed to put more attention and to collect more data. I think the more recent work that has been done has demonstrated that whilst there is some additional risk, for example, in transport workers or meat processing workers or people who are exposed, for example, to members of the public, it is not as great a risk as it was originally thought. Now we've done those more detailed analyses. And I think it also comes back to the point that I was making earlier, that it's very difficult to say that one workplace is more risky than another. It's actually a complex mix of factors that determines that risk. And actually understanding how those risk factors coalesce in particular environments is becoming, I think, increasingly important for us to understand. And to give you an example, we know that there are areas of enduring prevalence of COVID in a sort of an arc from the northwest through Yorkshire and Humber down through the Midlands, and explaining why that is the case and continue to be the case is again something we're looking at, because that will help us to pick how these different risks that come together in particular circumstances, transmission to be greater and the cases of COVID to be greater. So it's quite a complicated picture, and I wouldn't want therefore to say this workplace is more dangerous than that workplace, because that wouldn't be an accurate reflection of what's really going on. But clearly some occupations have an increased risk compared to others from the epidemiological work that's been done.
Let me ask you specifically then. About 6 months into the epidemic, I wrote to the ONS and asked them about the death rates for people working in supermarkets, shop workers effectively. And they wrote back and said that for men, the rate of death was 75% higher than you would get in their cohort, and for women it was 65%. Are you saying I can't draw any conclusions from that about the safety for workers in supermarkets?
I think what you can say is that obviously it depends on the analysis that ONS did and how they corrected for confounding factors, and I'm not aware what was done there.
I think they did correct for socio-economic background.
Okay, well if they connected for socio-economic and ethnicity, then clearly that would indicate that there was an increased risk in those groups. I'm not sure that from any of the other work that I've seen that supermarket workers come out particularly at risk, but I think clearly the thing that would be of concern for supermarket workers potentially is that the exposure to the public, who may not be taking precautionary measures such as wearing face coverings, etc., might provide the opportunity for them to be exposed to more virus. But again, it depends on what's going on in the supermarket itself, how the controls are being managed, what the ventilation looks like, what the specific mitigations are that the supermarkets have put in place, which do vary quite significantly.
I can understand your caution in trying to put figures on the different routes for transmission, but would it be safe to say that surface transmission is close to zero?
It wouldn't, no. So, for example, I was very interested in what Professor Mondali was talking about, and I agree totally that measuring in the real world is really important, and that's something that we've been doing when we've been going out and investigating outbreaks. So, to give you an example of a recent outbreak that we investigated, which was in an office, we went in and took samples from all around the office, and we found very high contamination of mRNA, SARS-CoV-2 mRNA, in the security bit. So the security was outsourced to a particular company. They were using a different risk assessment model, and we found a lot of evidence of viral contamination in the office that they were using. We found it on, for example, the handles of the windows in that office as well. So therefore, that's why I wouldn't say that there is zero risk from surface transmission, because we can find mRNA, which is not the same as live virus. It's an indicator that there's a lot of virus in the space on a lot of surfaces in that particular example, and many other examples where we've been to food processing factories, where again you can find it not so much in the work area, but in the locker rooms, the canteens, the toilets, etc., the sort of work associated areas. So that's why I don't think you can say with certainty that surface transmission can be ruled out.
But you don't have evidence. You have evidence of contamination, but not transmission. Is that fair to say?
And it will be very, very difficult to do that. To try to demonstrate that it wasn't. It was purely surface rather than air would be a very difficult thing to do.
Right. Given that air transmission appears to be the main route, do you have a view on the effectiveness of masks?
Depends what you mean by mask. So I would divide them into two categories. I'd first of all talk about face coverings, so the kind of thing, this sort of fluid-resistant surgical mask, which is what you see primarily out and about. Good for source control. So if I'm wearing one of those, I am protecting other people from me, essentially. Probably gives me a little bit of protection from other people, but primarily it's acting as source control. If you then move into what we in HSE would describe as respiratory protective equipment, which has got proper standards and what have you, then obviously the different standards would determine the level of protection that you get. So typically in a high-risk area in a hospital, you might be using an FFP3 respiratory mask and wearing that after having been face-fit tested. So you can't just sort of put one on and assume it's going to work. You have to test to make sure that it actually fits your particular face and it's providing you with the protection that you need. So yes, masks have a role to play, but it's really important to understand what they do and what they don't do when working out how they can help you to control the risks that you are trying to manage.
Can I just ask a final question to Professor Mondelli? We are possibly this winter, Professor Mondelli, facing not only infection from COVID, but from influenza. Do you think you could briefly tell us the difference between the transmission routes of influenza and COVID, and whether the same non-pharmaceutical interventions, masks, for instance, and other precautions, would be the same for flu as they are for COVID?
Well, thank you for asking. Essentially, flu is transmitted very similarly to SARS-CoV-2, and with a probably more risk played by inanimate surfaces here. But there is no real evidence supporting that, just impression and data coming from early studies on. I think barrier methods such as masks will play a significant role. In Italy, for example, we saw a real drop in transmission of flu during the lockdown, even the first lockdown. So the social distancing and masks were enough to really demonstrate a drop in other respiratory viruses, particularly. I believe that flu shots is also very helpful. So the response rate in terms of vaccination of the entire population is very minimal compared to the SARS-CoV-2 immunization. In Italy, for example, for reasons that are not completely apparent, before COVID, we had only a 33% response rate for even in the elderly. And that is not, it is probably a cultural attitude. Maybe people thought that flu was not so dangerous, but everybody knows that flu can be dangerous and fragile. So, and because several flu waves have been witnessed during the at least 4 different waves due to antigenic drifting and demonstrated since the first flu pandemic. So coming back to barrier method, I believe that mask is very, very important, and there is evidence that mask is really protecting from respiratory viral infection. There's a very large study conducted in India in COVID, which shows that even surgical masks that are not really perfect, as Professor Karan said, are enough to significantly reduce. Obviously, FFP2 masks are much better, but they're heavy to wear along the day, I mean, we do it in the wards, of course, and when seeing outpatients, because we have to do, but really going beyond 6 hours with those kind of masks, this is not as difficult for surgical masks, which are protective, as I said. So I think, I believe this was topic.
Thank you.
Question.
Thank you.
Thank you, Graham. Just before I turn to Carol, Professor Curran, you mentioned research that you've done over the last year. Does the Health and Safety Executive consider formally international research in making its recommendations?
Absolutely, yes. So, for example, one of the things that we did very early in the pandemic was activate our international networks. So one of which is the Partnership for European Research into Occupational Safety and Health. We had an agreement with all of the countries involved in that, and there are 13 countries, 14 different institutions across those 13 countries, that we would share information on a very rapid basis. And in fact, our colleagues in Austria set up a platform to enable us to do that. That meant that we could get very rapid access to information that was emerging. For example, on masks, there were some questions early doors about reuse of masks and cleaning of masks. We could see what colleagues in Switzerland were doing because they had started that work earlier. So that was extremely helpful to us, and that work and collaboration has continued. And similarly, I chair something called the Sheffield Group, which is the international network of national health and safety labs. And again, we ask questions of that global network around various issues during the course of the pandemic, and again got that international perspective on what we were doing. So that international view has always fed into what we do in a really practical, focused way.
So the work that Professor Mondelli has described, is that something that you've made an evaluation of?
Yes, so certainly the work that the Professor Mondelli's talked about actually I think has been considered very recently by UK HSA, who've just published a systematic review of face coverings, which included international members on its steering panel.
Particularly of surface transmission?
Yeah, so certainly in our national core study, we are reviewing the literature all over the world at all times. And that plays into not just the interpretation that we make, but also directs some of the experimentation that we do to make sure that we are, not just focusing on a very small view of the world, but taking in that global perspective. Absolutely.
Thank you. And Professor Mondelli, you described your study that found that there was very limited potential for transmission in a hospital setting from surfaces, from fomites. But Professor Curran mentioned that there was the presence of mRNA detected, not necessarily transmission, but the presence detected on surfaces. What would you have an explanation for why that might be the case?
An explanation of why mRNA was present on the surfaces. Well,
the implications of that. Does the presence of mRNA would that lead to concerns about transmission, and how does that compare with your study in the hospital?
Well, we didn't look for mRNA in our initial studies last year, but certainly the presence of mRNA would suggest that the message for synthesizing proteins are there. Now, whether this mRNA is viable in terms of actually producing viable viruses has not been shown, of course. And the only experiment or test that we have available to suggest that the RNA that is found on surfaces is actually able to promote spread of the virus, at least in vitro, is the infection of susceptible cells. These are Vero6 cells, a special clone of the Vero cells from monkey kidney. And these cells can be used for a variety of reasons, also to calculate the neutralization potential of antibodies elicited by vaccination with the vaccine that we have available against COVID. So finding mRNA, we must say that RNA is a a ribonucleic acid is susceptible to degradation compared to DNA, which is much more resistant. RNA is probably very quickly denatured and unable to transmit the infection and transduce the protein that are essential to form the complete virus and to give rise to a proper replication procedure and construction of new variants. So I think it is interesting that mRNA has been found on surfaces, but this unfortunately does not prove that such an RNA may be responsible for infection.
Thank you very much.
For the reason that I've just mentioned.
Thank you. Carol Monaghan, then Rebecca Long-Bailey.
Thank you, Chair. Professor Mondelli, can I just ask a little bit further on that? You're talking about the mRNA degrading. How quickly would that happen?
Well, within minutes, from minutes to hours. It depends on the environmental conditions. For example, the humidity and temperature, they play a significant role. UV radiation may be another factor. That's why we keep on saying that summer will reduce transmission of SARS-CoV-2. Unfortunately, this applies to a particular UV light, UV rays that are the type C UV rays, and not the common type A and B that reaches the ground on Earth. The type C are largely blocked by the ozone barrier. There's, of course, I said RNA is much more prone to degradation. And in fact, other DNA virus can resist more in the environment, such as, for example, hepatitis B, that could even sent in very standard packages around the nation several years ago when in Italy there was much control the condition. 50 years ago there was no specific containers, and then you could send blood samples without specific container, yet you could be able to elicit an infectious virus. So this is usually not possible for RNA virus. There is a lot, even among RNA virus.
Carol?
Thank you. Professor Curran, given what we're hearing from Professor Mondelli this morning about his studies and about other information he's taken, are we focusing, or have we focused too much on surface transmission?
I think we could have focused more on airborne transmission at the start, definitely. I think we have corrected that. There has been a big sort of move towards identifying the need to improve ventilation, for example, to make sure that spaces are appropriately managed from an occupancy perspective. But I don't want to overemphasize the potential for surface transmission, but I also wouldn't want to rule it out. As Professor Mondelli says, identifying mRNA on a surface is not evidence of transmission, but we have also been able to grow live virus from surfaces that have been swabbed outside the hospital environment. This is work that's been done by one of the groups within our National Core Study Consortium, using samples from homes, for example, and remote controls and telephones and that kind of thing. They have been able to grow live virus. So therefore, that, if you like, is the missing link between can live virus be picked up from surfaces? Yes, it can in those studies, as yet unpublished. So that's why we haven't majored on that yet. But that is something that I think will come out over time. It's very difficult to do, to measure live virus on surfaces. It's also very difficult to measure it in air samples. So again, that step between measuring, if you like, a marker of exposure, the messenger RNA, and actually demonstrating that that is associated with the live virus is a very difficult thing to do, not just for surfaces, but also for air. And only a small number of groups around the world have been able to do that.
You've said a few times, and Professor Mandeli said that as well, that evidence of virus doesn't mean evidence of transmission, which I think is important. The WHO has said that there are no specific reports which have directly demonstrated fomite transmission. Does that mean that there's 0 cases of COVID been picked up from a surface?
The challenge is, of course, finding an example where you could isolate the fomite route alone, because to actually do the kind of work that would enable you to demonstrate that is, as I said earlier, very, very complicated. It's like, if you work on the basis that transmission is a continuous risk, actually working out where you got it, if you suddenly are tested positive, is very difficult, because it could be in any one of any locations that you have been subjected to from the minute you get up to the minute you go to bed. So actually being able to demonstrate very specific issues like that depend on your ability to identify some very specific exposure scenarios where, for example, every other route had been eliminated, as it were, and you could say, yes, definitely, that is fomite transmission. I'm trying desperately to think of one, but I can't off the top of my head, and I think that's the problem. It's very hard to be able to isolate very clearly, given that transmission is a continuous risk, and those 3 routes of exposure are all absolutely possible.
Yeah, thank
If
you.
sorry, if I may, can I add something?
Yes, please.
I think there are 2 critical factors here as well, and I agree with Professor Karen. One is timing. I mean, are we sure that the virus that can be isolated from surfaces is really been there for some time, or has been just spit by somebody who sneezed on the surfaces and it's quite fresh? So it's difficult to determine for how long the RNA has been there. Probably it's been there for only a few minutes. My feeling is that the virus, if transmitted at all by surfaces of fomites, it should be freshly spit on the given surface to be infectious. That's one point. The other point, to demonstrate that a particular clone of virus has been responsible for transmission to a third person, you have to sequence the virus retrieved from the fomite oral surface and the virus that is present at any given time in a patient that has allegedly been exposed to the surface. So
And
as
of
you can
course
see,
that
it's
patient-
extremely...
That patient might
extremely
have touched
difficult.
many other surfaces as well, so I can see that that would become
Yes.
almost impossible.
I mean, you can model everything, but when you come to evidence, to hard evidence, it's really very difficult to demonstrate transmission, that actually transmission has occurred from the surface to a patient.
Thank you. Thank you. Professor Karen, one of the pieces of evidence we took early on was about the kind of composition of SAGE, and we found that there were overemphasis of certain types of experts and probably less of others, for example, engineers. And we know that engineers have been instrumental in demonstrating airborne transmission. So did we consult them early enough in the pandemic?
Obviously, I would leave, it's not really my role to comment on SAGE. What I can comment on is the fact that I think it was about April last year, I was asked by Sir Patrick Vallance to set up a subgroup of SAGE called the Environmental Modelling Subgroup of SAGE, which I did with Professor Catherine Oakes, who's already appeared at this committee last year with myself. And what we established was a team of experts, including engineers, including building engineers, including mathematical modelers with experience of computational fluid dynamics who could look at the spread of virus, microbiologists with experience of how to control transmission through, for example, air cleaning devices. So we pulled together, I think, a world-class team that also had access to international collaborations and networks that they had already, to answer some of those difficult questions about engineering controls, what we understood about the movement of aerosols in rooms, so the physics behind all of that. And that information was fed into SAGE and has been regularly since April last year. So I think SAGE has had access to a very significant group of individuals with extensive experience in this space and has made use of that information. If you only look at the number of SAGE papers that have been produced since then, I think in that space it did.
Can I ask you on that, because you're saying April last year, but it took until April this year for the WHO to make a statement about aerosol transmission. But in your view, why do you think it took them so long?
Obviously, I would leave WHO to comment on that. But I think if you look back, as I did over the last few days in preparation for this meeting, as to what we said in the very first SAGE paper that we contributed from that environmental modelling group, a lot of what we said then, I think, still is relevant today. So we talked about the airborne route. We talked about how you mitigate using a risk assessment methodology backed up by a hierarchy of control. All of those things are still very relevant, and also have more evidence to back them up.
Yeah,
so,
and I think all of that, I mean, that information was conveyed well, and I think people understood that, but it's just, I mean, this understanding why the WHO didn't update their guidance.
Yeah, well, obviously I'm not party to how the WHO goes through its decision-making process, but as I say, what we've been able to provide is evidence to show that that airborne route is very important, right back in April 2020.
Thank you.
Thank you very much, Carol. Rebecca Long-Bailey.
Thank you. Thank you both for coming to speak to the committee today. Just to start with a very general question, I'm sure you'll both be aware that, as I understand it, the UK currently has one of the highest weekly rates of transmission in the world. So how should the government plan and prioritise interventions to lower transmission risk at this time? Starting with Professor Curran.
Yes, I mean, the numbers are there for everybody to see. I think one of the things that obviously I can speak to as HSE's Chief Scientific Advisor is that HSE has provided practical advice throughout the pandemic and continues to do that to make sure that people have access to the best available guidance as to how to put in place the most effective mitigations to manage exposure via those three routes. Starting with, as I've already said, the risk assessment process. And actually, that, I think, is a very useful starting point for anybody to think about what they do, how they do it, and to recognise that the risk is there continuously. And I think there was a bit of an issue at the start of the pandemic where people were very keen to identify a particular work activity and focus on a particular element of work without thinking, actually, how do I get to work? What, do I meet my kids at the school gate? All those other things that can introduce transmission risk. So that's why I think the guidance has to include every citizen, because every citizen needs to be making an informed decision about what they do and why they do it. And I think from an HSE perspective, we try to make that practical, pragmatic. For example, I think our ventilation guidance is extremely helpful because it's a very complicated issue to work out whether your ventilation is working or not. So I think whilst the cases are high, obviously the information needs to be made available to people so that they can make informed choices. Ultimately, I suppose it depends on what the objective is. Is it to get to a certain number of cases? Is it to get to a certain number of hospitalizations? Or is it to get to any other endpoint on that journey? Because case numbers on their own are an indication of how much virus is in the environment, not how much damage is being caused by the virus per se. So it's, again, a complicated set of issues that lead you to a particular path, and that's where obviously the decision makers come in as opposed to scientists who are just providing the evidence.
Thank you. And Professor Mundelli, what should the UK government be doing at this time to lower transmission risk?
Well, I believe to reinstate the obligation to wear a mask in closed environments, that's very important. I think try to improve the vaccine acceptance beyond. I think you have about 78% or less people receiving having received 2 doses. I think we both should reach 90%. We're just about 80%. We have a less dangerous situation at the moment, but we hope we'll manage like that. I think social distancing, wearing masks inside, avoid grouping of too many people, and implementing the vaccinations and showing evidence of vaccinations. You know, we have a huge discussion about exhibiting green passes for work, or having access to restaurants or theaters or cinemas. I think despite all these protests, we need to be firm and to implement those very simple guidances that they're common sense, but they are absolutely essential to control the
Thank you, Professor Mandeli. Professor Curran, you mentioned HSE risk assessments, and I understand that guidance was issued by HSE when the restrictions were gradually eased. Are you content that the current mitigations that are in place in workplaces, if indeed they're actually being followed by particular workplaces, are actually sufficient to limit transmission at this time?
I think one of the things that HSE has been able to do during the course of the pandemic is respond to the changing evidence base and provide updates to guidance as appropriate. Obviously working closely with BEIS, who produced the better working guidance. And I think that ability to work across traditional departmental boundaries has been very good actually during the pandemic, and certainly my CSA colleagues have worked very closely together to make sure that we're getting the right evidence into the right bits of the system. I think to check whether things were actually being done appropriately, HSE instigated a series of spot inspections, and therefore we've had sort of boots on the ground. We've had people calling companies, following that up, as I say, with visits. And you can start to see that, you know, from those, I can't remember the exact number, but it's something like 330,000 spot inspections, that the vast majority of organisations that we have been to, which have either come to us because people have raised concerns or because they've been identified as being in a particular risk category, the vast majority of those, well over 90%, are doing things that meet the guidance. And I think our inspectors have identified that the majority of employers that they've spoken to have got a desire to do things right. That's not to say that everybody gets it right, but I think certainly from my perspective, I've been very impressed as to how people have put in place what are simple but effective things to reduce the opportunity for transmission. We've seen it again in the work we're doing in our national core study, where we go out again to real workplaces and see what's going on. And the best solutions are those that are co-created by the employers and the employees, because they're the best people to work out what they do, where the risks are, and thinking about the whole process from start to finish. And you know, by rearranging a production line, or providing a different rota system, or making sure that breaks are taken differently. There are a whole range of things that people can do that make a massive difference. And where it's been done well, I think that it's made a big difference to the potential for transmission. But that's not to forget that in some workplaces it hasn't been done as well as anybody would have liked. So I think the vast majority have done a great job. I think some clearly haven't.
That's very helpful. And you mentioned a case earlier on where in one particular workplace a contractor had been following a different risk assessment model to the workers that were employed in another part of the office. Do you think that the HSE's guidance needs to be more stringent, and if so, what would you like to see change going forward?
I think it illustrates some of the complexities of modern workplaces, actually, you know, where you probably don't always have the simple single controlling mind within an organisation. You might have a number of different contractual relationships. You know, you might have a different caterer, you might have a different security company, you might have a different facilities management company. And I think one of the things that COVID has done has shone a spotlight on how those different organisational arrangements, if they're not properly thought through, can, if you like, lead to issues around what I would call the interfaces in these complex systems. because it's really important that when it comes to something like COVID, which doesn't actually respect contractual arrangements or organisational differences, that everybody's on the same page and everybody's thinking about the risks, which will be the same for all the people working in that space. And therefore the risk assessment process needs to take that into consideration. And that's something I think that is a learning point for everybody, in fact, in the context of how we manage risks going forward, because the world of work has changed and will continue to change, and we need to think how the processes that are tried and tested since 1974 can be made appropriately to manage in that situation. And I think, my experience has been that the Health and Safety at Work Act has provided a fantastic bedrock for this country to have one of the safest working environments anywhere in the world. And therefore, I think it's got a good track record and probably just needs more conversation about how to make it work in those complex circumstances.
Thanks, that's really helpful. And on the issue of spot inspections, you mentioned that there had been 330,000 spot inspections so far by the HSE. Could you confirm the date upon which those spot inspections began? And if you're able to, you might not have this information, but what were the key determinants of how a business was selected for a spot inspection? Was it limited to certain sectors that were more at risk, or was a widespread chosen deliberately to cover all sectors?
I think that's probably a question better asked at my regulatory colleagues. But what I can say is that as of the 15th of October, we have done 330,229 spot checks and investigated 741 outbreaks as HSE. So that's a huge amount of information, and that information is also now feeding into our national core study, because we recognise that the data that has been collected as part of that process is really important, because as Professor Mondelli said, as I've said, that view of the real world is one of the things that's absolutely critical to understand what's actually going on, as opposed to what we think might be going on. And that's why I always come back to this point that with transmission being a continuous risk, with workplaces being very complex environments, you've really got to get into the detail to work out exactly what's going on, because you can't necessarily say that all meat processing factories are the same or all offices are the same. But what you do need to understand, and what our study is starting to unravel now, are the key risk factors that might come together in different combinations in different workplaces to cause an increased risk to those workers and employers who are in that space.
Thank you, Professor Curran. I can see you've got a lot of graphs there. I wonder if on any of those graphs it shows what proportion of workplaces of that 330,000 actually were in compliance with HSE guidance and how many weren't.
Well, the way the spot checks work is that they look to make sure that the workplace is complying with the guidance, public health guidance or the workplace working safely guidance. The printing is very small, but from memory, it's about 96%. So, that's why I think there is good evidence that UK workplaces have taken this seriously. 330,000 is not all workplaces in the UK, I totally accept that. But of those workplaces that we have been to, both from telephone contact and actually going and looking at the workplace, the vast majority, as I say, greater than 90%, have put effective mitigations in place that comply with the guidance laid out.
Thank you very much. And finally, Professor Mondelli, as I referenced earlier, the UK does have one of the highest weekly rates of reported cases in the world. Are you aware of what mitigation measures other countries have in place that are successful at the moment in lowering transmission rates?
Well, most of the countries are really following what we have been doing in Italy. So wearing masks in indoor and exhibiting, trying to reach all the population with vaccine. There are a number of people also in Italy that are declared no vax, or there are some vax uncertain people as well. While you cannot do anything about convincing no vax people to vaccinate themselves, we can do a lot with teaching and information to try to convince the uncertain people. There's still quite a lot out there. We believe we have 3 million people that have not been vaccinated. Another important point, I think, is to implement vaccination in children from 5 to 12, because common sense is that the children, at least last year, did have a very mild disease, but in fact there are some complications in children that can be avoided by reaching them. And the adverse effects are quite manageable and not life-threatening. I think, I'm not sure whether you have the same thing in Britain, and it seems that you don't. What we call Green Pass, which is evidence of vaccination or evidence of having a nasopharyngeal swab in the previous 48 hours. I think using a rapid swab is probably not enough to be absolutely sure that the patient is not, that the subject is not non-infectious. It's not infectious. So the elementary guides of social distancing, wearing masks, and particularly indoor, get as many people vaccinated. These are 3 very important issues that can be responsible for mitigating transmission of the virus.
Thank you.
Thank you, that's very helpful.
Thank you very much indeed, Rebecca. Just finally for me to Professor Curran. At the beginning of the pandemic, we were seeing through it less darkly. We didn't know what were the principal routes of transmission. We're nearly 2 years on, and we know more about routes of transmission. Has the guidance on fomite transmission, that's to say surface transmission, changed? Has the HSE guidance changed on that?
I don't think it has, no, and I think it hasn't because we can't rule it out as a route of transmission, as I've said throughout the...
You say you can't rule it out, Professor Curran, but the work of HSE in many other areas of national life is making some judgments as to what is the appropriate level of risk and applying expertise to that. Are you following that practice here, or are you following an approach that is providing sort of ultimate caution so that we all have these white sanitizers, you've got them there, that is costly at the margin to people, to organisations, to businesses, and to the environment in terms of what is there. Are you being rigorous in maintaining the same restrictions now after nearly 2 years when we know so much more about surface transmission?
I think it's important to recognise, number one, that obviously it's the responsibility of the duty holder to assess the risk that their activities are generating. So if, for example, the work that they do does not generate the risk of surface transmission, then they do not need to put in place mitigation for surface transmission. So HSE doesn't mandate...
But my point is the relative... What we know, and Professor Mondelli has been very clear, that in a rigorous study, there wasn't any evidence of significant contamination in a hospital setting. The evidence at the beginning, perfectly reasonable to follow it, was experimental, and our colleague Graham Stringer pointed out that the WHO have not been able to find any evidence of fomite transmission. Now, we've discussed that it might be hard to do that, but it seems to me that nearly 2 years on, surely HSE should be looking again at this. Have you got plans to look again at this?
Obviously, we keep the evidence under continuous review. So,
well, do you? Tell me, what review have you conducted recently around that?
Well, so for example, obviously one of the issues that we've looked at recently, bearing in mind that there is no evidence for airborne transmission of the same kind when it comes to fomite transmission. So you can't measure live virus in the air very easily. So you're making judgments there as well as to the relative importance of those two routes. But certainly, for example, we've looked very significantly at our ventilation guidance. We've looked very significantly at our guidance on carbon dioxide monitoring.
I'm talking particularly about surface transmission.
In terms of surface transmission, we keep the evidence base under review, and we
But
haven't
I'm asking
identified.
about can we see the papers that you've taken on this?
Yes, well, all the information that we would use are the SAGE papers. So the SAGE papers that look at the routes of transmission, the risks of transmission, the virus characteristics, etc., are the bits of information that we will use to determine whether a review of the evidence that we are undertaking in terms of our guidance would be required. And as things stand, we haven't seen that from a surface transmission perspective any need to change that guidance at present.
But has HSE reviewed whether the guidance that you have on surface transmission remains appropriate?
I'd have to check with my policy colleagues, but certainly I have regular conversations with all of my...
Well, you're the chief scientific advisor, you would know, I'm sure.
Exactly. So I have regular conversations with my policy colleagues. We have regular meetings where we review those new evidence statements, but there has not been, as I say, the requirement based on the evidence that we have been using, i.e. the evidence from SAGE, to suggest that we would need to reduce the advice that we're giving on surface contamination, because I just don't think the evidence says you can rule it out. So if you can't rule it out, then I don't think it's appropriate to say you should stop cleaning regimes to the level that are currently in place, because that would be based on very, very limited evidence, and of course that I don't think would be appropriate.
Is that the normal standard of the HSE, that you have to take action if you can't rule a risk out?
Well, I think obviously the information on COVID is slightly different, and we're dealing with a national pandemic here, aren't we? So it's really important that we consider what are the potential routes of exposure for this particular issue. When we're looking at all other risks, obviously we take the whole situation into account. We take our evidence from the practical side of work, we take it from the experimental side of work, and that then determines the guidance that we would provide in a standard way.
Thank you. Well, I'd be very grateful if perhaps after this hearing you'd write to us with a summary of what formal evaluations you've made of the requirement to continue the same guidance that's been in place since the beginning of the pandemic.
Happy to do that.
We're very grateful to you. We've overrun our appointment with you slightly, but that's because it has been such an interesting area. So can I thank you, Professor Curran, and Professor Mondelli for joining us from Italy, giving us the benefit of your expertise. We're very grateful for that.
It was a pleasure. Many thanks.
Thank you very much indeed. We're now going to go to our second panel of witnesses. And I am going to welcome two very expert witnesses to discuss vaccines. And we're very grateful to have back with us Professor Sir Andrew Pollard, Professor of Paediatric Infection and Immunology at the University of Oxford, and as we all know, the Chief Trial Investigator of the Oxford AstraZeneca vaccine trial. Thank you very much indeed for helping the committee again today. And joining us from Israel, Dr. Sharon Alroy-Price. Dr. Alroy-Price is Director of Public Health Services in Israel. Thank you very much indeed for joining us and informing our committee today. Perhaps I can start with a couple of questions, perhaps starting with Sir Andrew. Sir Andrew, when you were last with us, it was in June of this year, and looking forward to what we know about the development, the likely development of COVID. You said that the likely course of the pandemic was that new variants would become more transmissible, but that the likelihood was that vaccines would continue to protect against severe illness. Does that remain your view?
It does remain my view that that's the case. I think one of the difficulties that that we have in all of these discussions at the moment is the rigorous understanding of the data. We were just talking a moment ago with Rebecca Long-Bailey's comment about very high case rates in the UK, which of course is true, but actually I'm sure you're referring to cases which is very much related to the amount of testing. And if you look across Western Europe, we have about 10 times more tests done each day than some other countries. This is per head of population. So we have to always adjust by looking at the data based on the rate. So we do have a lot of transmission at the moment, but it's not right to say that that those rates are really telling us something that we can compare internationally. Now, interestingly, Israel also has a very high testing rate and picks up a lot more cases than many other countries. And so a lot of our policy decisions should be very much focused on what we think is right for this country, not by saying other countries have much less, because it's very difficult to make those assessments. And if you make the adjustment of cases in relation to the rate of testing, so to sort of look at test positivity, actually currently Germany has the highest test positivity rate in Europe. So I think when we look at these data, it's really important not to sort of bash the UK with our very high case rate, because actually it's partly related to our very high testing rate. I'm not trying to deny that there's plenty of transmission at the moment, because there is, but it's just the comparisons that are problematic.
Thank you, that's extremely helpful. And just to take that further, again, when you were with us in June, you warned that we, irrespective of the level of testing, you warned that we shouldn't be over-focused on positive tests, because the likely course was, as you thought at the time, that more people would contract COVID, and therefore that we could unnecessarily worry about levels of infection, which, if things worked out as you anticipated, would rise, but that the key, as it were, sort of test of how alarmed we should be is severity of disease and hospitalisation. Is that?
That's absolutely right. So I think we have to now look at also the rigour of the data when we look at hospitalisations and deaths. So if we take some of those different segments, so for example, intensive care admissions, the vast majority of those remain the unvaccinated. And so the whole question about booster doses and so on, and whether the vaccines are failing, in terms of that severe disease, we remain in the situation that the way to control those is for those unvaccinated people to be vaccinated. Now, you could argue that all the other measures, having more people vaccinated, more people boosted, mask wearing and so on, will also have an impact, because of course it will do, on those unvaccinated individuals. So if we want to protect intensive care, there are measures to do that, as we did last year with non-pharmaceutical interventions, but also we could be vaccinating those individuals and focusing on that bit, which would protect intensive care.
Thank you.
Now, if you look at hospital admissions, which is a slightly different measure, generally speaking, that is quite a different story from last year. If you remember last year, with no vaccine programme, hospital admissions were a relatively serious consequence of COVID infection, with severe lower respiratory lung disease and sadly many people going to intensive care and dying and overwhelming the intensive care units. Whereas today, although there are some people whose immunity has flagged, the vast majority of people going in are not following that same course. Hospital length of stay is much shorter. Those individuals who are going in have a much milder disease. And interestingly, many of them have other underlying health conditions which are destabilised by having a relatively mild COVID infection. And of course we see that as, physicians see that every winter with other viruses, that people who are frail with various health conditions will be tipped over the edge as a result of those viral infections. And COVID is doing that as well. So if we put further downward pressure on COVID, those admissions would stop. But I think it's partly here we have to think about what the long term, or at least the main question is: are we trying to look at sort of trying to protect the NHS by what we're discussing today? And I think that is probably the main question that's being raised certainly in the media and in Parliament at the moment. But when you look at where the NHS is today, it is incredibly fragile, whether it's in primary care, in secondary care, or in social care. And that fragility is only contributed a small amount by COVID. And so vaccinating is not going to suddenly make the NHS okay and not be on its knees where it is at the moment. Certainly the pandemic has had a major impact on that with waiting lists and so on. So can vaccination make a difference? Yes, it will. It certainly more vaccines for the unvaccinated will make a big difference to intensive care. Booster doses for those who are frail will likely reduce some of the admissions in those who are frail, but this still doesn't change the overall needle on where we are with a very stressed NHS.
Thank you. Obviously, we've embarked on a booster programme. The reason for that, for most people other than those with diminished immune systems, is because of waning protection of the vaccines. Am I right in thinking that one has to kind of, as it were, deconstruct waning? There are two aspects of waning protection. One is from contracting COVID and the other is from severity of disease. Sometimes they're conflated. Is that right to draw a distinction?
I think it is absolutely right to draw a distinction. And if we look at cases in the community, because of the escape of the virus from neutralising antibody is important for controlling infection per se, then we've seen, despite a vaccinated population, transmission in that community. It doesn't mean that the vaccines are not working at all, because the transmission is much lower than it would be in an unvaccinated population with the amount of social contacts we have. But the virus is evolving all the time. There's a new variant, as you're aware of, that may take off and is a bit better at transmitting and therefore escaping those immune mechanisms. And I think that is our long-term future with this virus. Now, if we boost, we will have much higher levels of antibodies, at least in the short term, which will help to control that. So boosting will get those numbers down and make us feel better that we're doing better than other countries if we're in that competitive world. But the key question in my mind is still what's happening with severe disease. And the severe disease is the intensive care unit admissions. Now, you can reduce those if you have less transmission, because we're protecting people by there being less virus out there. But in the end, the unvaccinated will meet the virus, and they will, if they're not vaccinated, those susceptible will end up in ICU. It just might not be today, it might be next year. So that's why I think we still have to focus on persuading those individuals who are unvaccinated to be vaccinated. But that transmission that we're talking about will still cause those milder hospital cases that are in those frailer individuals, and boosting can reduce their risk of that happening.
Thank you. And just finally, from me to you on this, given what you said, does it give you any concern that, for perfectly understandable reasons, we've become familiar with looking at the daily figures on new transmissions and the charts that are put up every night on the news, compare them? The graph goes right back to the beginning of the pandemic, but we ought not to be as concerned today about any given level of transmission as we were in the past. And do we run the risk of being worried about the wrong thing?
Well, I think it comes back to the rigour of understanding the data we look at, and I think it's presented in that simple way, because that's the only way you really could do it in real time. I mean, there isn't time to do the detailed analysis of what those figures mean. But it's important to remember, if we look at deaths, that is deaths within 28 days of a positive test. So if you have a lot of transmission in the community, lots of people will die from lots of other causes that are not COVID, but will be included in the numbers. And I think if you look at the death certificate data, or you look at the more detailed analysis that's done later, you see much lower COVID death rates, because of course lots of people have died having recently had a positive test but didn't die from COVID. So the death rates are quite misleading at a time of high COVID in the community. Secondly, the hospital admission data are also misleading, because they're also generated in real time. There isn't the coding that happens in the NHS, which takes quite some weeks after the hospital admission to actually work out what the person was admitted for. So if I'm admitted for appendicitis today and I had a COVID positive test, that will appear in the daily data. And of course, again, if you've got lots of transmission in the community, the hospital admission data that we look at each day will reflect the fact that whatever you go into hospital with, a proportion of people will have been positive in the last month. So I think we really have to look in more granular detail at the formal analyses that are done, rather than looking at just the raw data, which are quite misleading. Now again, it's important to emphasise that doesn't mean there isn't COVID transmission and people being hospitalised with it. It's just that the rigour of how we look at the data needs to be addressed here.
Do you have any feel for, any lens into what the proportions are of people who are recorded as having died within 28 days of a positive COVID test? People that died of COVID, as it were, rather than died of something that they were admitted to hospital of alongside COVID?
I don't have those numbers. I think we need to have some formal look at the data, and you have to then link the two data sets together to be sure that you're looking at the same groups of individuals in order to make that to give that answer. So I don't have that. But I mean, I think when you look in the community, for example, we see these very high rates of transmission. But of course, in some parts of the country, the vast majority of those come from very effective testing in schools. And so we're picking up a lot of very mild infections, and we know from all of the previous studies done that children contribute a relatively small amount to adult transmission. So that very high number in some regions, a proportion of cases, is reflecting something which is transmission amongst children of much less importance than transmission to older adults.
Thank you very much indeed. Now, before I come to Diana Davison, just to turn to Dr. Elroy-Price. So Israel has been much in the news over the last 2 years and much studied. You were very early to vaccinate the population, but then you've experienced a rise in the level of infections recently, and you've brought in a booster program. Explain this to us. Does it conform to what Sir Andrew has been describing, that it's people who are being infected but not necessarily severely ill?
So thank you for inviting me. I have to start with saying that I think every country has the obligation to do their own decision based on their own setting. And I'm not here to say what the UK needs to do, but just to explain what happened in Israel. What we saw in Israel is that we got to a high coverage of the population in around March of 21, which is about 60% of the population covered. And we have young population, about a third of our population was not eligible for vaccination. And still we got to 60% coverage. And in June, we started to see the daily cases rising by more than 100-fold in a month and a half, from about 10 cases a day, confirmed cases a day, to more than 1,000. And what was more worrisome is your question. We saw the same rise in severe cases. So we had a rise of more than 10-fold in severe cases in a month, and 60% of them were doubly vaccinated. So that was an alarming signal for us. And when we looked at the data, we saw that there was a twice or 3 times more risk for people who were vaccinated early on in January compared to those who were vaccinated later on in March and April. And so it was clear that at least part of the picture was waning immunity. Another thing that was helping us is looking at the UK data, seeing that the vaccine effectiveness in the UK remained high, around 88%. From what was reported, whereas in Israel, the vaccine effectiveness dropped to, at the beginning, 60%, then 40%. And at the beginning, it was just for confirmed cases, but the severe cases effectiveness remained high. And as time passed, it got into being reduced vaccine effectiveness also for severe cases. So seeing all this picture together, in addition to our vaccine effectiveness among 12 to 15 years old, where we saw that was teenagers who had a fresh vaccine. They were approved of the vaccine in June, And so when we got to this rise in cases in July, they were still in the time frame when they didn't have still waning immunity. And for them, we saw vaccine effectiveness of around 90%. So we knew it's not the issue of the Delta itself. It's not the variant that is causing the most of the problem, although it contributed to some extent, because with Alpha variant, we saw vaccine effectiveness of 95, 96%. So there was some drop, but the main surge in cases was due to waning immunity. And so this led us to go to a booster campaign, starting with the older age groups and then going down by steps.
Thank you. And just briefly, give us a thumbnail sketch of the impact of that as it's discernible already.
Yeah, so on a personal level, what you see is someone who is getting a booster dose and have a fresh vaccine is more than 10 times protected against severe disease, confirmed cases, any confirmed cases, but also severe disease, especially in those who are 40 and above. But on a national level, what we saw is a drop in the surge of cases. So before we started the booster campaign, we were in reproductive number of 1.3, 1.4 for weeks. It was really high number, causing us to double our confirmed cases every week, every 10 days. This is how we got from about 10 cases a day to more than 1,000. And once we started the booster campaign, the reproductive number went down. Now we are between 0.7, 0.8. So the pandemic surge is now shrinking. And what we're seeing is dropping cases, obviously in the vaccinated individuals, but also in the non-vaccinated. So we're getting to the point that the vaccinated individuals are also protecting those who cannot be vaccinated.
Thank you very much indeed. Diana Davison.
Thank you very much, Chair. And Dr. Alroy-Price, I'll stick with you if that's okay, and thank you for joining us today. I'm keen to get a proper understanding of, I suppose, the decision-making process and the research that was done behind the introduction of the booster vaccines. I think the world's been watching very closely what's been going on in Israel, given your sort of pioneering nature throughout COVID. But what research was actually conducted into the waning immunity, and was that particularly waning immunity around infections, or were you really seeing that manifest in hospitals as well?
We saw it in everything. The beginning was seeing this in confirmed cases. We were looking, since the beginning of the vaccination campaign in our Ministry of Health, we were following the vaccine effectiveness since January, and saw a really high level of effectiveness once we got the vaccine going. And it was around 95%. And then in the beginning of our fourth wave, we saw a drop first to 60%, still remaining very high, 95% for severe cases and for mortality. But as time went by, as I said, we saw a drop in that too. And I have to say that in that point in time, knowing that Israel was the first to vaccinate, I think we were about 3 months ahead of the rest of the world in our vaccine campaign. We reached high level of coverage in March. I think compared to the UK, you reached it in around June. So there is a 3 months period where we can see the effect of waning before other countries will do. And so once we saw that, we actually brought together a group of scientists from 4 leading academic institutions in Israel. I can tell you their names, but I'm not sure if it tell you anything, but really tried to see if different scientists that are looking at the data by different statistical methods will get to the same result, to make sure that we're not making any type of mistake. And so there was a really unique collaboration of those 4 institutions, making sure that we are seeing what we're seeing. And what we saw was waning immunity, first for confirmed cases, but also for severe disease, for mortality in the ages of 60 and above. And now, with time going by, we also were able to show a statistically significant difference for 40 and above, severe disease and mortality.
Diana?
And so, how was the decision made in terms of the point at which to implement the booster vaccines? Because there is a debate going on in the UK at the moment around whether 6 months is the most effective or whether we reduce that to 5 months. How was that decision made in Israel?
So in Israel, we have very much like the FDA, we have a vaccine advisory committee that is advising the Ministry of Health. It has several professionals in there, infectious disease epidemiologists, lab scientists, and others who are there voluntarily giving their advice, and the data was shared with them repeatedly. So I think we brought it to the advisory committee, I think 3 times before we all felt really safe. They're voting. And so in the first 2 rounds of voting, most of the people voted that booster is not recommended yet. We saw the same thing, confirmed infection. We said, okay, but the severe disease is not really impacted by that. And as more and more data was gathered, we saw the effect on severe disease. Then the advisory committee voted for booster dose first for 60 and above and healthcare workers, and then expanded it to other age groups as we went by. So we have a process in Israel of a committee of about 60, 70 individuals, professionals in different sectors, advising the Ministry of Health, and then the CEO, the director of the Ministry of Health, is actually making the decision based on their recommendation.
And in terms of the time period between the sort of initial vaccination program and the booster period, what length of time is that, and was that quite heavily debated?
We started seeing the rising cases in around mid of June, and we started the booster campaign for the 60 and above at the end of July. So we really saw an exponential rise in cases, in severe cases, and so we had to act quickly. Based on our predictions, if we had not done the booster and remained at a reproductive number of 1.3, 1.4, with the numbers rising and doubling every week or 10 days, we would have gotten to 1,500 severe cases in our hospitals at the end of August. And this was above the ability of our hospitals to take care of. So we had to really move quickly. But as I said, there were at least 2 meetings where people didn't feel that there was enough data to suggest it. And only when we saw really impact on severe cases was there an approval to go ahead with the booster dose for the elderly.
And have you found that the actual take-up of the booster doses has been similar to the initial vaccination program, or have you seen people sort of dropping off?
So it's different between the older age groups and the younger age groups. With the older age groups, I think the compliance was very high, and it was very similar to the first wave. With younger age groups, there was some hesitant among people feeling that maybe they're not maybe they're not at risk. And again, as we saw more and more cases of people who are 40, 45, 50, could have one chronic disease or none at all, doubly vaccinated, getting into severe and critical conditions in the hospital, people started, the compliance went up. And we're above 50% compliance even in those age groups. Another thing that is helping that, it's not the purpose of it, but it's helping that, is the Green Pass. As mentioned in Italy, we have a Green Pass in Israel, and so once the disease surge goes up, we implement a Green Pass where you need to show either a vaccination certificate or recovery certificate or do negative tests. And I think that is also leading younger individuals who don't feel at risk be vaccinated with a booster dose.
Thank you, Dr. Alroy-Price. And if I have time, Chair, can I ask a quick question to Sir Andrew as well? You mentioned there that you think that one of the huge risks is actually the unvaccinated population, and they're probably those presenting in hospital with severe illness. At the moment, the government's got this advertising sort of campaign to encourage people to take up the booster jab, but do you think the government should perhaps be doing more to encourage people to actually take up the initial and first and second dose?
Well, I think as our colleagues in Israel have shown, that there's no doubt that if you use a booster, you'll get a big increase in immune responses. We've got good data across all of the vaccines that we use here to show that. And that will have further downward pressure on the virus, just like all of the other things like mask wearing will. So in respect of could the booster program have a protective effect for the unvaccinated, the answer is yes. But I think my case here really is that in the long run, if we take a long-term view, those individuals remain at risk. The virus isn't going to completely disappear. So the unvaccinated still need to be vaccinated. And so I think we do need to do all we can to encourage them to be vaccinated as well.
Great, thank you.
Thank you very much indeed, Dan. I'll bring in Catherine in a second, then Carol. I wonder what you have in mind, Sir Andrew, in terms of the effectiveness of the vaccines, perhaps the one that you're responsible for. What is the difference between its effectiveness against transmission and against severe disease? What are the relevant percentages?
We're seeing much lower protection with Delta against infection. So these are, the question about transmission is much more murky. But if you look at infection in the community, yes, so we see much lower rates of effectiveness there, and I think that was very clearly shown also in Israel. Where the dominant vaccine used is the Pfizer vaccine. So
what sort of percentage are we talking about?
Well, it depends on which study you look at, but somewhere around 50 or below 50%. Yeah. Some of the studies it's around 40% for the vaccines that are currently being used. So if you're looking at what's likely to happen in the future, the virus is going to evolve to be able to transmit even better. So I would expect that number to be going down over time. Because we know that it's the neutralizing antibodies the virus is escaping from, and that will result in a lower measure of effectiveness. The key question to me remains the severe disease one. Indeed. And the severe disease figures stay extremely high. So if you look at the best analyses that are being done, we're still somewhere between 80 and 95% in the UK against severe disease. As I say, the difficulty is actually doing these analyses in populations with very high vaccine coverage. Just to rehearse that a little bit, if essentially what you're trying to do is to see whether what the rate of severe disease in those who are vaccinated versus those who aren't vaccinated. Those who are vaccinated and have had 2 doses, much higher rates in the elderly than in younger age groups. The unvaccinated, a high proportion of those now, an increasingly proportion, have been infected, and we know that infection will also give you protection. So you're trying to say how effective is the vaccine in relation to a control population.
It's diminishing.
Well, they're diminishing, but also many of them are already immune, so they're no longer true unprotected individuals because they've had infection. And so it becomes increasingly difficult to measure what's actually changing over time in effectiveness. And then, of course, we've got the other problem. If you want to know what effectiveness is in an 80-year-old, most of the studies that are done don't have enough unvaccinated 80-year-olds to do that comparison. So you have to compare with a younger age group who obviously have a completely different set of risks from an 80-year-old. And so we have a great difficulty at this moment in being certain about effectiveness figures because they're so confounded by the remarkable programs that we have that have protected so many people, and of course this infection in the community. So we do have very high levels, but I don't think when you look at any of these numbers that they're absolute truth, because they're really difficult studies to do.
Very good. Thank you very much. Catherine Fletcher and then Carol Monaghan.
Thank you, Chair. Sorry, I thought erroneously that you might have got me. Dr. Alroy Priest, hope I've said that right. Thank you so much for your time. It's hugely appreciated. You kind of given your knowledge across the oceans, as it were. I just wanted to return back to this idea of the escaping of or waning of immunity and understand the root cause of it. So you've been quite clear that a variant in the COVID virus itself is unlikely to have been the cause of the waning immunity. I just wondered if you'd had any opportunity to work out whether different vaccine types have different rates of waning, and also whether it was the dosage interval that was delivered in Israel that perhaps might cause it. Maybe, to help us learn some lessons in the UK, whether you could just talk to those 2 points.
So that was a great question. We don't have much information in Israel from different vaccines. The main vaccine we've used has been the Pfizer, especially early on. Now we're using other vaccines, but early on, we had mainly Pfizer vaccines to give. And so this is what most of the population got. But there is a high amount of research on that topic showing the waning from across the world, showing waning for other types of vaccine as well, whether it's Moderna, whether it's AstraZeneca, Johnson & Johnson. So there is a lot of data showing that there is waning. The question about the whether part of the waning is because of the protocol that we use, the FDA-approved protocol of 3 weeks apart between the first and second dose, is a really good question that I don't have an answer to, because I think part of the difference between Israel and the UK is also the time frame. So if we are 3 months ahead, we'll see the waning 3 months before you see the waning. So I'm not sure if part of what we're seeing is because of the protocol that was 3 weeks apart versus 12 weeks apart, or because we are seeing just the waning first. And maybe with time, we'll see, we'll have the answer for that. But I think the point about who are we comparing to, and are we basically comparing our vaccine effectiveness to those who have been recovered, and we know that they are protected. We have data to also show this because we're following the recovered and their rate of recurrence of disease. It's a challenge. It really is a challenge.
Fair play, thank you. Professor Sir-Pollard, are we doing anything with our broader spread of vaccination types to kind of track relative effectiveness?
I think so. It's a really important question, and so I completely agree with the difficulties in making these comparisons, except in countries where you've done things exactly the same. And of course, we haven't done that here either, in that we've used the vaccines in slightly different populations. So if you see differences between them, it may just be that there's differences between the populations that you vaccinated rather than that it's differences in waning. I think what we have in the analyses being done in the UK at the moment is quite a confusing picture. So the ONS study from about a month ago suggested that Pfizer was waning in protection against mild infection more rapidly than AstraZeneca. The Public Health England study suggests that AstraZeneca is waning more rapidly than Pfizer is. And so I think to actually work out what the truth is difficult. The important point is that if there is some waning of protection, it is still relatively minor at the moment. And it's not suddenly falling off a cliff. And I think this is a point I've made before, is that we would not anticipate the protection to suddenly fall off a cliff. It may decline somewhat, but certainly with severe disease like that, it just doesn't make biological sense for that to happen. The US has some data looking at waning, which suggests that Moderna may be slightly better than Pfizer in terms of producing stronger, more long-lasting immune responses. But I think all of these are slightly difficult to interpret. And if you go to the hospitals, then intensive care units in this country, and I accept that Israel may be different, is largely the unvaccinated. And in on the wards, we do have hospitalizations with people, but they tend to be people with other health conditions who are a subset of the population who may not have responded so well and may wane more quickly.
That's really helpful. So in essence, we're almost at the point with this pandemic where we're down to almost personalised medicine and the variant factors that might make it's a much longer study. But the clear message is, if you haven't got jabbed, at some point, if you're at risk, you could end up on an intensive care ward.
I think that is the absolute key.
Yeah.
If you've been vaccinated, even in the context of waning, you're in a very much better position than anyone who's unvaccinated.
Fair enough. Thank you.
But boosters that are being rolled out at the moment are going to have an additional impact on that, because it will raise the immune responses higher.
Thank you. Thank you,
Thank you
Jim.
very much. Carol Moran.
Professor Pollard, why Pfizer for the boosters?
I wasn't party to the discussions about which vaccine to use. My guess is that it is that when you look at the strength of the immune response, so this isn't about protection because we know people are highly protected, but the strongest immune responses are likely to be with the RNA vaccines. So that's probably the rationale. I don't know whether it's, there will also be other questions over what's available, what the supply is and so on, but I'm not party to those discussions.
Okay, thank you. Dr. Alroy Price, if I could come to you. you've talked about your vaccination programme for children. Can I check, first of all, are you giving your 12 to 17-year-olds 2 doses?
Yes.
Okay. And what impact has this had on infection numbers?
So once we started the vaccination program for the 12 to 15, at the beginning of that program was when we were between waves, and so the compliance was not very high. Once we started our 4th wave, and the compliance went up for 12 to 15, and we're about 60% coverage for that age group now. We saw a reduction by about a half in the number of cases, and to some extent even more than that. That's the underestimation is half. So it has an impact on cases, of confirmed cases for that age group. I think we all know for the 12 to 15 years old, the risk of severe disease is really low if you're a healthy young child or teenager. So we could not see an impact on hospitalization, obviously, but the vaccine effectiveness for that age group was around 90%.
Did you see any impact after the first dose? Because in the UK we're only doing 1 dose at the moment.
For us, we were seeing, what we saw is that 1 dose is giving a vaccine effectiveness of about 40%, 40 to 50%. This is the same number that we saw in our first vaccination campaign. We're looking at the vaccine effectiveness of full protocol versus someone who is midway, and what are their disease, the rate of disease among those individuals. And so it's roughly 40 to 50% for 1 dose. We are recommending for everyone to get a full protocol, which means a first dose and after 3 weeks another dose.
And one of the concerns about the vaccination of young people is the instances of myocarditis. Have you seen any instances of this in Israel?
Yeah, so in our I'll start with the first vaccination campaign, which was for the 16 and above. And what we saw among more than 3 million people vaccinated is 142 cases occurring myocarditis. We actually published this after seeing that there is a connection to the vaccine, mostly in males aged 16 to 30, and mostly after the 2nd dose of the vaccine in the first week after the vaccine. 95% of the cases were mild and discharged without any sequela. And in another research done by one of our biggest HMOs, Clalit HMO, who followed 2 million people and looked at the data after discharge. For the Ministry of Health, we don't have the follow-up data, but they looked and saw that in all of their cases, there was full recovery, even when they looked at imaging studies like ECHO and other types of data that they had. So what we are concluding from that is, yes, there is a risk of myocarditis, especially in the 60 to 30, especially in males, especially after the 2nd dose. But in most cases, that risk is of mild disease. And so we are still recommending that. When we rolled the 12 to 15 years old, we didn't see the same rate. We saw a lower rate of myocarditis in that age group.
Okay, because I was going to ask, was there any consideration to giving the 12 to 15-year-olds a single dose? But if you're saying you didn't have the same rate of myocarditis, was that one of the considerations when you were given the 2nd dose?
Yeah, that was one of the consideration. And the second one was really that the clinical manifestation of the myocarditis was mild in most cases. And so there is risk that the event is rare, it's not common, but even when it happens, it's a mild disease. And so the risk, and again, this is a research done by Clalit, looking at their data, that the risk of myocarditis from COVID-19 is higher when you have a disease than you have vaccination. So if you are dealing with a disease surge and you have many cases and the risk of you contracting COVID-19 is high, then the risk of myocarditis as a side effect from the disease itself is actually higher than from the vaccine. And this is why during our fourth wave, when we got to 10,000 cases a day for several days, we encouraged people, teenagers 12 to 15, to take the vaccine, knowing that even if you have this adverse event, it's mild for the most part. And then once it was rolled out, we saw that the events were at a lower rate at that age group.
Thank you. And Professor Pollard, the UK has only given a single dose to 12 to 17-year-olds. What do you consider the impact might be in hospitalisations and severe infections?
Well, I think the first thing to say is that the second dose, as I understand, is still under consideration. It's not that it is only going to be a single dose, it's just the decision hasn't been made yet. I think the other important point here is that we've already had a lot of infections in teenagers, which will essentially, for priming their immune system, will be like having had a first dose. So for a lot of people, that single dose is like having a second dose. But of course, there is still a proportion of individuals who have not had a first or second dose. And if we want to reduce both the risk of infection and the very, very rare chance of severe disease in children, and then certainly getting the first dose will have an impact on that. And if it may be that second doses will be decided upon at some point in the future.
Okay, so you wouldn't know more about the considerations that have been taken, so it would be things like we've heard already.
I think the main issue here is to fully assess the myocarditis data to make a decision on the second dose.
And how soon do you think that decision will happen?
I'm not involved in that discussion.
Okay,
when they'll make those decisions.
Thank you, Chair.
Thank you very much indeed, Carol. Obviously, it is tremendously good news, and we ought to kind of pause to reflect on the fact that we're discussing a context of continuing high efficacy against severe disease from the vaccines that we have available. There are some groups for whom that's not true. People with blood cancers, for example, are finding that the vaccines are not providing the protection that others do, that other groups have. In your work at Oxford, do you have any insight into what might be available other than shielding, but what interventions might be available that might offer some hope for such groups?
I think the first thing, of course, is we now do have a policy which is to select those individuals who are immunocompromised, not just the blood cancers, but the wider group, to have what's being called a third dose. And that's because of the observation that there are some individuals who make very little response with the first two doses, but then giving them another dose does get them started up. And so that program will help some individuals. What's not clear at the moment is how long that being souped up lasts for if you're one of those individuals. But there are still some who won't respond to vaccines, and that's many different conditions, not just the blood cancers. And for those individuals, there's essentially two approaches. One is the use of monoclonal antibodies, which have recently started becoming available, and the second is the use of antiviral drugs. And I not someone who's actually been working on those areas, but both of those provide potential additional benefits for those individuals who can't respond to vaccines.
And of course we should put on record, as we highlighted in our report, the role of treatments, which has developed considerably thanks to research efforts. Thinking about, going back to what you were saying at the beginning, Sir Andrew, about the level of testing being higher in this country than in other countries, and this giving a higher number of cases. And you said that a lot of that is in schools. Given that in schools, we've heard both from Israel and here that young people tend to have a very mild experience of COVID if they get it. And you yourself have said today and before that actually having COVID provides the equivalent of a dose of one of the vaccines. Are we being too cautious in having such a rigorous testing regime in schools, and in schools at least, should we not be a bit more relaxed about transmission?
Well, I think the first thing is it's absolutely critical that we keep children in schools, and we've seen the biggest impact of the pandemic on children has been missing school and the psychological effects that there have been of that. So I really think all of the policy decisions should be focused on that. Clearly, the large amount of testing in schools is very disruptive to the system, whether that is the individual child who is then isolating because they've tested positive but they're completely well, or it's because of the concerns that raises more widely in the school. And we're of course aware of families taking their children out because someone's tested positive in a school. So I think there is a huge impact of widespread testing in schools. I think probably we need to move in the pandemic over this winter, maybe towards the end of the winter, to a completely different system of clinically driven testing. In other words, testing people who are unwell rather than having regular testing of those people who are well, because that does drive a lot of these actions that happen particularly in schools if you're having lots of asymptomatic testing. Symptomatic testing, if someone is unwell, as should normally happen, they shouldn't be going to school. But that isn't a COVID-specific issue. That should be a general rule that if someone has the flu, they should be at home and not at school.
You say in the course of this winter, you're clearly describing a move towards in the long term, which is consistent with your view that in the long term, COVID is going to be in circulation, and if we're vaccinated, the vast majority of people get it in mild form rather than severe form. If one were to move towards that, given the mildness of the experience of children, would not schools be the best place to start that transition, as it were?
I think it's a good place to start that transition. We are, at the moment, if you remember, when JCVI looked at vaccinating adolescents, their view was that there were likely to be marginal benefits in doing so overall in the population. And so they actually came down with a view not to. And it was after the review by the chief medical officers that the decision was to roll out vaccination. And I think because the benefits from a COVID perspective are marginal, it's reasonable to take either view, to either vaccinate or to not vaccinate. But the reason for the vaccine programme that the chief medical officers had was to keep children in school. And so I think we have to absolutely do that as part of that contract with families, that the children are being vaccinated because we want them to be staying in school.
Mm-hmm. So in terms of the implications for the testing programme, and one of the things that our joint inquiry was critical of the test and trace programme was not to anticipate what was ahead in terms of the demands. And obviously any use of public money is at the expense of some other use of public money. Do you think that we should be preparing ourselves in the medium term for a lower level of testing of asymptomatic people and gearing ourselves up for a different model of testing?
I mean, I think that's an inevitable future anyway. I mean, we're not going to be testing at this rate for COVID forever, so we need to think about how that transition works. And as I've said, there clearly is a lot more transmission at the moment, and that does add some additional pressures on the NHS because there are some individuals going into hospital and more than there were before. But I think we are in an improving situation because of high vaccination coverage that we have. The booster programme will start limiting even further the number of cases, and particularly those hospitalised cases. And actually there's lots of infection that's happened in the community which is boosting lots of the younger people as well, including children. So all of that is an improving situation with higher levels of population immunity, which means at some point we will reach a more steady state with this virus that is likely to be more manageable. The problem is we don't know exactly when that is, and there may still be some surprises around the corner, but so there's uncertainty.
And finally, when you've appeared before the committee before and in other public fora, on boosters, you worried not that boosters will not be effective and useful, but actually they may be more useful applied to other countries that haven't had first doses. Have you does that continue to be your view? Would you prefer that we were sending them to places to protect people for the first time?
I think we are still in that window where there are many countries with very low rates of vaccination, and particularly in Africa, but it's not solely in Africa. And for individuals in those risk groups, so the older adults, those with other health conditions, a dosing that could be given to those individuals has a much greater benefit to that individual than a booster dose to any of us. So I think that there is still, from a global equity point of view, a strong argument for more actively sharing doses. Obviously today we've been talking about the domestic situation. Indeed. And from a domestic perspective there are some additional benefits, but they're much more marginal than the benefits of vaccinating someone who's completely unvaccinated and is an older adult. That, I hope, is an improving situation over the next 6 months, but it does very much depend on what happens with supply. And the whole issue around supply is if the whole world decides to start boosting now, then those countries that were behind will be left even further behind. So I think there is that issue there. One other thing just to pick up on that was talked about earlier was the timing of the boosters, which I think is a really important question. And there's no doubt that if you boost, and as Israel did at almost any point, you're going to boost immune responses and have better protection. If you take a long-term view, then you would boost as late as possible. So that's why the 6 months has been considered. And this is based on immunological principles. There isn't a great data set that says for COVID vaccines and each individual one of them when the right time to boost is. But generally speaking, if you leave enough time for the immune response to mature and for the previous antibody levels to have dropped a bit, you get a better boost. So the 6 months figure, or with some vaccines we do it at a year or even at later points, means that you get a stronger impact. So the question really is whether you have enough of a problem to bring forward the doses. Are we facing a disastrous winter and we need to boost everyone earlier, which would be completely rational if that's the case. And we need the modelers to help us with that. But if actually we're taking a long-term view as we want to have protection over the next year or even more than that, then having the booster later from an immunological point of view is better. And so the policy is more difficult because you have to look at what's happening now, but the long-term view would be to boost later.
Thank you. I see that, and I suppose to kind of bring it to full circle, do you think that there's a danger that high levels of infection reported panic us into bringing forward a booster program or the interval that actually is at the expense of longer term protection for reasons that go beyond what is clinically necessary?
I think it's highly unlikely that boosting at 5.5 months or 6.5 months makes any difference. So I don't think what's being proposed is problematic one way or the other. But if we were thinking of boosting people much earlier, I think that would be unwise, and it's also not needed.
Is there any advantage in boosting much later, say a year?
Well, we don't have the data for the COVID vaccines to answer that, to say what difference in magnitude or duration would be achieved. So I think 6 months is a good compromise. That's what we've done with many vaccines in the past, and we see very good responses. I see Sharon has her hand up.
Dr. Elroy-Price.
I know there are different approaches to kids' infections because mainly the active disease, when it happens, it's mainly mild or asymptomatic. But I do want to say here that part of what is influencing our decision making is the effect of long COVID. And when we looked at that, and actually I saw also data from the UK supporting this, that 1 in 7 or 8 kids have continuous symptoms after recovery. We saw the same thing in our research that we did among 14,000 parents of recovered kids, and we saw in the age group of 12 to 18 that there was around 5% of the kids, even 6 months after recovery, still having symptoms from long COVID. So that's one thing. The other things is PIMS, the multi-inflammatory response that happens, and we think that it's happening more here in Delta than we saw before. We're actually looking at the data right now. So that's another risk. And And the third risk is the unknown. We have many viruses that can create complications years after an asymptomatic infection to begin with. So we are actually looking very cautiously about infections in kids, kids that are still are coming in contact with a confirmed case needs isolation. We're now in a program of a green class, trying to get them back in school, because I'm completely in agreement that we want kids in school as much as possible, but trying to make it safe for them and trying to find the settings in which we have more infection spread among those green classes, and trying to stop them or prevent them from happening, but allowing the 80% that do not have spread of infection when you have a confirmed case in the school, allowing those kids at least to learn in a frontal learning. And what I think our approach is trying to be is lower the number of cases. Once the number of cases, confirmed cases, is coming down, then we have less risk for kids, less isolation, more kids in school. It is challenging with the surge of disease, and but still, even though we are performing 80,000 cases tests a day, we're seeing a drop in the percentage of positive test results. So we're remaining very high on testing and seeing a drop in infection rate. So this is what we're trying to aim. And I know that there are different approaches, and I think with the uncertainty that is happening here, probably every approach can be justified, but this is the Israeli approach.
Well, Dr. Arora-Price, we're very grateful for having that directly from you. We've said in the reports that we've issued, it's very important that we should look at what other countries are doing, grappling with a virus that affects the whole world, and to have your direct testimony is a real privilege. Very grateful for that. And we're grateful, as ever, to you, Sir Andrew, for helping the committee think through the next steps. You have made a signal contribution to getting us to where we are today, and we're very grateful for your continued guidance. Thank you both for appearing today.
Thank you.
Thank you.
We'll now move on to our third and final set of witnesses, who are just going to join us at the table. I will introduce them as they are taking their seats at the table here in the committee room. We're going to discuss preparations and prospects for this winter. And to help us do that, I'm delighted to welcome Professor Sir Stephen Holgate. Professor Holgate is Professor of Immunopharmacology at the University of Southampton and Chair of the Academy of Medical Sciences Expert Advisory Group, which carried out, at the request of the government's Chief Scientific Advisor, reports last year and this year into preparing for winter. Thank you very much, Sir Stephen, for joining us. I'm very pleased to welcome Professor Lucy Chappell. Professor Chappell is the Chief Scientific Advisor, quite recently appointed at the Department of Health and Social Care. And Dr. Thomas Waite, welcome back to the committee. Dr. Waite has helped us before, and Dr. Waite is currently the interim Deputy Chief Medical Officer and has been since the beginning of July. Thank you very much indeed, all, for appearing. Perhaps I can start with Sir Stephen, and perhaps if you would, you'd summarise the advice that you, on behalf of your colleagues in the Academy of Medical Sciences, gave to Sir Patrick and therefore to the nation about what we should be doing to prepare for this winter.
Yes, thank you very much, and thank you for inviting me to speak to you. Well, of course, this was the second report, and we had already experienced, of course, during the first report, whether or not any of the predictions that we came up with in that first report actually panned out over the following 12 months. And as it turned out, they did. Partly because of the incoming Delta variant of this virus, which obviously accelerated the transmission of the virus. So in the second report, we were tasked with the opportunity to look back as well as look forward, to think about the winter and beyond the winter as to what steps might be taken to protect the community. And I think there were three things really that we were particularly focusing our attention on. The first was, of course, the virus itself, and we had a lot of discussion today about that, and the possibility of variants of the virus emerging, and those variants accelerating the transmission and severity of disease. So that was the one area. So we had a section on the virus side, and you've heard a lot about that this morning. The second is the impact that the virus would have, but also winter would have on the National Health Service itself. And that, of course, is the ability of the system to be able to cope with more than a winter that we've had experience of in previous years. And part of the problem with that is the fact that while we've been obviously trying to boost immunity to this particular virus, there are a whole raft of other viruses that, by the very actions that we took in terms of the physical distancing, the mask wearing and staying at home and all of that, those other viruses never appeared last year. And it's absolutely dramatic. If you look at the graphs of all the other viruses, RSV, syncytial virus, the influenza viruses, of course, even the common cold viruses, all of them completely flat. And even if we look this year, just last week, looking at those other viruses, they're beginning to kick up a little bit. And the difference really that this has made has been huge, because obviously if you have a pre-existing condition like asthma or chronic obstructive lung disease, and you get a common cold virus, for example, it really causes a serious problem for those individuals. So that was the second area, the emergence of viruses outside. And then the final one, of course, is the ability of the workforce itself to be able to withstand another round of all of this. And we've heard evidence today, hopefully, that it's not going to be as bad. I work at Southampton General Hospital, and I have to say we are seeing COVID cases in intensive care unit at Southampton General Hospital. To say that these things actually are just picking up the virus incidentally, I think we need more evidence for that, because certainly my respiratory colleagues are being exercised now by new COVID. Nothing like we had last year, of course, but still there. So that's an important concern. And we have a very distinct concern about the health of the workforce, really, both in terms of numbers, which we've heard a lot about in recent days, but also the actual ability of that workforce to be able to deliver. And by that, I don't just mean the hospital service, I mean the primary care infrastructure as well. So those are the three areas we concentrated on. We made some recommendations that really stem from, many of which actually are being implemented, so this is not in any way a critical thing. But I think our predictions that we made about the magnitude of the hit, if I could use that term, in terms of the virus itself, are probably less than we anticipated. But obviously, from the discussion you've just been having, we'll see where that pans out.
Well, thank you very much, Sir Stephen. That's a very good introduction. Perhaps briefly turning to Professor Chappell. You've heard, you were good enough to sit through some of the previous evidence. You've heard that we have a very high or comparatively high level of incidence of COVID in the population at the moment. But the difference between this winter and last winter is that vastly more people are protected by the vaccine. Do you share the concern that Andrew had, that we ought to be driven by hospitalisation rather than, as it were, the more sort of superficial level of infection in the community?
I think we need to take all of those pieces of information into account when we're looking at where we are now and where we might be going, because they're giving us different bits of information, and I think it would be a mistake to go purely for one or the other. So we've seen the rise in cases, particularly in the 10 to 19-year-old group, and we are now seeing some rises, smaller rises in the parent group, the 30 to 49, and a much less rise, but a small one in the older age groups. So I agree that it's both a balance between the number of cases and the wider impact, for example, on hospitalisations, intensive care unit use for COVID and deaths, and would suggest that we take all of those into account.
But do you accept Sir Andrew's point that the rise in prevalence, the rise in incidence of COVID is entirely predictable? That is what you would predict of the course of this virus.
I think it depends on where we are in the pandemic, and we're going to see rises and falls as we have done through it. But it's also very dependent, for example, on behavioural, on the intersection between vaccines, boosters, waning, and behavioural changes. So the modelling has been shared, and we've got modelling from SPI-M and from the other groups, and they're all suggesting that we are not heading towards a rise. They are all suggesting that numbers may be coming down, but it's modelling. It's not a perfect forecast of what's going to happen. It's very much more giving us some scenarios. But those scenarios depend on all the other human factors and population factors relating, as I say, to vaccines and behaviour.
Would you be worried about a continuing high level of transmission if the level of hospitalisation remained low and stable?
They're telling us different things, and they're telling us where we may need to input. So, for example, if hospitalisations remain fairly stable, then we need to look at the impact of other respiratory viruses on hospitalisations, and also on the indirect effects of COVID on the backlog. If we have ongoing high number of cases, that will have some ongoing forward transmission, and that's why promoting vaccination, both first vaccinations in older age groups and in the 12 to 15-year-old groups, and booster vaccinations is so crucial, because vaccination reduces infection, and if you don't have COVID, you can't transmit. So they are all very interlinked, and the message needs to be clear that vaccination is one important part alongside the other components.
Indeed, and that is the first recommendation in Sir Stephen's colleagues' advice for winter preparedness. But nevertheless, we know that vaccines have an impact on transmission, on infection, and they have an impact on the severity of the disease. We've heard directly from Sir Andrew that the impact, the protection against severe disease is very much greater than that of transmission. So again, if we had, let's assume that we're going to go all out for vaccination. Yep. If the level of hospitalisation from COVID continues to be at stable levels, would you consider a high level of infection in the community cause to call for or to favour non-pharmaceutical interventions to be added?
I don't think we should be using infection in the community alone. I think it has to be considered with the whole package, and I think what we are seeing now is consideration of all the information that we have from the surveillance. Dr. Waite might want to talk more from that point of view on how to best inform the policy.
I'll come to Dr. Waite in a second. And of course, it's perfectly easy and reasonable to think that we should take all data into account. That's obvious. But decisions need to be made, and if the level of protection against severe illness and hospitalisation continues, even though, as Sir Andrew expects, protection against transmission will fall over time, why should that lead to, but why should it even be considered a factor in contemplating non-pharmaceutical interventions?
I follow. So I'll draw a comparison. When we had no vaccinations, we knew that the level of cases was a good indicator of subsequent pressure on the health service. So in this situation, I can see that you can say, well, level of cases doesn't translate into hospitalisation, but there are other factors such as take up a booster. I'm glad to see that we've got 6.1 million booster shots now delivered, and that we've got half of the over 50s. So continuation of that booster campaign against what Sir Andrew was describing in terms of waning immunity mean that we shouldn't just abandon case counting as an indicator, because I think...
So just on that point,
yeah.
so you made a strong case that we should have the take-up of the boosters as being a significant factor, because otherwise immune protection would wane. But if that continues, or if that is positive, then what is the connection between case rates if that is succeeding?
So I think seeing the increase in case rates gives us an indication some weeks ahead of where we might be going with hospitalisation. It informs the models that will then have us better prepared. We know from our colleagues, whether it's in intensive care units or emergency medicine or primary care, that we don't want to be acting in the moment. We want to be as prepared as possible, and I think as long as we are using that information in the round rather than all of our policy being driven by the case rate only, which I don't see, I see it as being one component of the decision making, of the evidence that informs the policy making.
To be clear, so Andrew, who has some eminence in these matters, having discovered the vaccine, he expects his own vaccine, as it were, over time to be less effective in preventing infection, but to continue to be effective in preventing hospitalisation. So it would be, if Sir Andrew is to be believed, it would be wrong, would it not, to infer that a rise in cases, which he predicts, should lead to alarm about hospitalisation?
So given that we are still within 12 months from our first vaccinations being rolled out, I think it is still early days to know exactly how vaccine waning and boosters will impact on hospitalisation. And I think whilst there are discussions ongoing about how the testing programme continues, as Sir Andrew said, into next spring and beyond, I think for this winter, it is clear that information gathering on testing and the link to tracing and isolation for cases is still likely to be beneficial, given that it's not just vaccination, it is also mixing. So whilst we've seen children mixing at the same rate as pre-pandemic, we haven't seen a return to adult mixing. So there are more factors involved in terms of transmission, infection and hospitalisation. And given that we're still sort of 10 months into this new vaccination, I still think that it is worth ensuring that we have a testing programme at this point.
Do you agree with Sir Andrew's view that we should be moving away from testing asymptomatic individuals and testing people that are ill?
There's a short-term perspective to this, and then there's a medium to long-term. So in the short term, I think we should be continuing with testing, particularly symptomatic individuals, and I know that other groups are evaluating at what point we reconsider testing asymptomatic individuals beyond January, beyond spring.
But that's the next decision, is it, when to turn off the testing of asymptomatic individuals?
Sorry,
that's the next decision. That
is being considered.
Wait, it's a question of timing rather
Yes.
than it's when rather than if.
I would like to think that in 5 years' time we won't all be lateral flow testing.
5 years. That's
So there's a stretchable point between now and 5 years, clearly.
Well, so Andrew referred to this winter, over the course of the winter.
So I think this winter spans between now and sort of January and then beyond. And I think between now and January, it's clear that we've committed to testing. We are then reconsidering where we go beyond January, beyond spring. But all of those need to react to the information that we have available and consider where we go.
Okay, finally for me to Dr. Waite, you heard again what Sir Andrew said about the people in hospital and people who have died within 28 days of a COVID positive test, that many of them had COVID because there's a high level of infection in the community, but it's not why they died. Do you have some insight as Deputy CMO of how that splits up in practice?
Thanks, Cheryl. With apologies, I don't think I was in the room when those comments were made, but in terms of the overall burden of disease within hospital and the risk of coming into hospital or indeed of being diagnosed, yes, we can split that down into a number of different groups, and that data is published by the NHS. First are those who are admitted with COVID at the point of admission. And the NHS will also make available another analysis, which is the number of people who have been diagnosed with COVID whilst in hospital. But it's quite important to then break that down further, because being diagnosed the day after admission would probably mean that you were COVID positive when you came in, and that's underlying your reason for being in hospital, whereas being diagnosed, say, 14 days after admission would suggest that you'd acquired that infection whilst you were in the hospital. So those are quite different groups.
Well, they are, but specifically the information that's required is whether someone that has died and had COVID, tested positive within 28 days, whether they have died because of COVID or because they've come in with having had a heart attack or a stroke.
Yeah, the risk of death with COVID sadly still remains very strongly associated with age, now also associated with vaccine status increasingly these days. And having COVID on top of a number of other pre-existing conditions can be a sort of a precipitator for going into hospital.
But it's important to have, and Sandra made the point, it's important to have that data to know, if it all turns on this, what is the level of protection from hospitalisation, it's absolutely essential that you need to know whether someone has died because they've had COVID, even if it's a contributory factor, or whether they just happen to have it and sadly would have died anyway. Given the huge importance of that, as Deputy Chief Medical Officer, do you have access to that information? And if not, what are you doing to get it?
The most recent ONS analysis I've seen in this, and the ONS statistics, I mean, we have some of the best mortality statistics in the world thanks to the ONS and UK statistics. And those are not updated on a daily basis, as it takes quite some time to compile death certificates, to look at the full details. Quite often there'll be cases that have gone to a coroner and so on and so forth. So there are good reasons why quite a lot of that data is delayed. The last ONS reports I saw on this, and I think they're quarterly updates, but I can certainly send the most recent update as and when it's available.
These are Office of National Statistics reports. They're not routinely reported by the NHS.
So the death statistics are compiled by the Office of National Statistics, and that, we have two forms or two streams of data during the pandemic, which we shouldn't sort of confuse. One is the very operational, very quick, the daily updates through the public-facing dashboard. That's to give us sort of a steer of where the trend is going. The much more detailed and fine analysis is the ONS quarterly updates, which we can rely on as being a sort of a gold standard, but one gives us an indicator as to where the other might be.
Given how important this is, it is possible to gather data in other ways. You could have a sample record inspection of records or interviews with clinicians to try to gauge this. Could you not? If a lot is riding on how many people are in hospital because of COVID, then surely, given the importance of that, and given that we're spending, over 30 billion on test and trace, that would be a sensible investment in information, would it not, to have something bespoke to try to answer that question?
I would suggest this isn't an indicator that's going to change very rapidly from day to day. So those ONS statistics would be sufficient for that. The last version of those, as I've seen, as I saw, Chair, the majority are cases where people have died because they have COVID.
Over 50% of people who've died in hospital within 28 days of a positive COVID test have died because of COVID, if I can put
Certainly on the last ONS update that I saw, and I can find the exact number, apologies, I don't have it with me today, but yes, it's still very relevant. The key things, though, are the reduction in risk of dying from having a vaccine gets greater and greater through older age groups. If you're, say, 70 to 79, being vaccinated reduces your risk of hospitalisation or of death to that of approximately a 30-year-old. That's very important for understanding the pressure on the NHS going on through the winter.
Right, so let me turn to my colleagues, Rebecca Long-Bailey, then Catherine Fletcher.
Thank you, and thank you all for coming today to the committee. So, Stephen, you mentioned earlier about the Academy of Medical Sciences report pointing to a number of other respiratory illnesses in the UK this winter. How worried should we be about this and the pressures that they will pose on the NHS?
Well, it looks so far, looking at the up-to-date data, that still we've got an extremely low level of these other viruses. So this is going to be 2 years now. And what's obviously going to happen is that we're going to lose or have an accelerated decline in our immune response to all of these when they do eventually hit. The second is that for influenza, which is the one we're most concerned about, I suppose, and we're doing obviously vaccinations starting soon on that, the nature of that influenza virus when it does hit it will be largely unknown, because normally you have a clue, because somewhere else in the world you've got the influenza breaking out and your vaccines are kind of tweaked to be able to deal with that, and we can remember the different influenzas we've had. So we're in a bit of double jeopardy here. We've got a waning population immunity to these other viruses, and we've got a question mark about the nature of the influenza when, because it will eventually hit, when it does hit. And I'm afraid at the moment we just can't answer that. The chances that these other viruses are going to have an effect is very high indeed. And in New Zealand, for example, which is on the other side of the world, they've been looking at RSV, for example. They've had a major resurgence there. And we had a September resurgence, or August-September resurgence here of RSV, though it's waning again now. Normally RSV doesn't go up until the winter. So this next 2 or 3 months is going to be interesting.
Okay. Yeah. Thank you. Now, as you know, the Academy's report suggested baseline interventions such as face masks and working from home where this was possible. Yeah. And over the last week, you've mentioned your own experience on the ground in hospital, but the British Medical Association is calling for those interventions now, the Plan B, if you like. What baseline interventions do you think the UK should be implementing now?
It's a really interesting question because, looking backwards, and I'll answer it directly in a minute, but looking backwards, we've come to accept that all these other respiratory viruses, like influenza, should harvest so many thousand deaths every year. That's normal. And yet, when we go to countries like Japan or Hong Kong or sometimes other Southeastern countries, people have worn masks, even outside of the COVID era. So this is a cultural thing here, and we've come to accept quite a high death rate, particularly 3 years ago we had a terrible death rate from influenza, which obviously would have been protected had people been wearing masks. So one answer to your question is, has this 2-year experience changed the threshold at which people are prepared to do these things? For me, distancing in crowded places, particularly, ventilation of rooms and the wearing of face masks are non-invasive things that people can do. And we are trusting the community and industry, as you talked about today, to do those things. Staying at home and working is another threshold. And I think that's really where we might have some debate, because obviously Plan B has staying at home and working, plus these other things. And I think plus these other things I would put in first myself. And if I could just conclude by saying that when people see other people wearing masks, they want to do it themselves. And I came in from Southampton today on the train, and I was the only person in a carriage 3/4 full wearing a mask. So that we can't rely on public's goodwill to be doing this. We need, I think, some more positive direction, and how that's shaped and what and how it's progressed. I am not in a state to be able to say, but I do feel personally that as we're going through this winter, with intergenerational mixing going to be happening across the Christmas period, that I would personally feel that. Our report says that. My experience is that, as a respiratory physician, is that we haven't seen it yet, and it's going to come.
Thank you. And on the issue of the government's Plan B, so far the committee struggled to get clarity on what would trigger a so-called Plan B. Are you able to divulge any information as to what measures are being assessed at the moment, what the trigger points are, whether Plan B interventions will be brought in a phased way, just to provide a little bit more information, because I think people watching from home today will simply want to know, is there going to be a Plan B, and when is that going to be triggered? Starting with Professor Chappell.
I'll outline the sort of overarching and then hand on for some specifics to Dr. Waite. So it's been considered, and it's been considered by SAGE, and the SAGE minutes are available. It's clear that we, slightly as we talked about earlier, there is no single metric that would lead to it. And there is a balance, which is why SAGE has provided advice and consideration of the possible measures and how they might mitigate relating to each of the components of Plan B. And because the impact of Plan B is very much on a societal level, it is, as you know, our view that we provide scientific advice, and it is then a policy decision by the ministers. Dr. Waite can talk more about the metrics themselves.
I don't think the metrics should be too much of a surprise to anybody. We've touched on case rates. Of course, age-stratified case rates are very much more important, I would say, than just looking at the single community measure. That's quite useful for a sort of a general understanding, but of course, case rates in 60 plus and 70 plus and 80 plus are very much more likely to be associated with hospital admissions. But it's not just those rates and the number of people going into hospital on a given day, it's the speed of change of all of those. So you could get to a given level of hospital admissions increasing by 1 or 2 a day over many, many, many weeks, or you could get there in a very rapid growth phase, and that would cause quite a different assessment of the situation. The third variable then that sort of tries to complicate those, I think Professor Pollard was talking about earlier on, is that of course vaccination has changed those relationships, and waning immunity will further change those relationships. We might expect to see over time a greater proportion of people aged over 60, for example, as they have a higher hospitalisation risk, going into hospital if they get infected, if their immunity is waning. That will change again as the booster programme rolls out, and that's sort of an unknown at the moment, is the extent to which that will further change these sort of ratios between the metrics. So it's a total picture, but I think from my perspective it's not a medical decision, the sort of the level at which society will say we would accept X number of cases or Y number of hospitalisations. That's very much a societal decision. That's why it's an important decision that ministers and Parliament would take in England, and obviously the devolved administrations as well, because it takes into account an awful lot of other factors. No interventions, certainly things like lockdowns and so on, are without even health disbenefits as well as benefits. And of course there's all the wider economic pieces, of which we're certainly not the experts there, we're doctors, but we would feed in through SAGE, which both Lucy and I sit on, the advice for those who have to take the decisions.
And is it the case that SAGE will be providing the government advice on when to trigger Plan B interventions? Because a lot of the historic SAGE advice hasn't really given direction, it's just set out what the picture is. So again, I think we're certainly exasperated within our communities as to what the trigger points are going to be, and I understand that the science is being assessed, but I've not heard anything today to suggest to me at all what the trigger points could be. Are they going to be determined by SAGE? Have they already been determined, and will they be published by the government as far as you're aware? Will there be any clarity at any point over the next few weeks?
Lucy might want to say more about SAGE's role in this, but this would be scientifically informed policy. SAGE would give advice, and ministers absolutely have to make the decision, not us. Another reason for that, as Professor Holgate was touching on, was of course other factors, even on health, would affect how you'd view the number of hospitalisations. If we see the extremely low levels of flu that we saw last year, about almost no flu last year, that would rather change the impact on the NHS of, say, 1,000 hospital admissions a day, which I think we've reached relatively recently. Similarly, RSV has come down, it's plateaued, it will probably go back up. These are the 2 weeks of the year when we usually do see flu and RSV start to go up. So there's a lot of other unknowns there. So we can provide that advice. What we can't say is that there is a single number, a magic number on any of those thresholds, because it's almost that web of interdependencies on all the other numbers. I don't know if you want to say more on SAGE there, Lucy.
Yes, I think we should also focus on what we can be doing and should be doing now, not just focusing on a single trigger. And I think, as Tom says, it needs to be more complicated than that, because we may setting sort of specific thresholds for X, Y, or Z. If you didn't consider them in the round, wouldn't be appropriate. It wouldn't be good science to say, well, it's going to be this number of this metric. So I think it reflects the more the broader approach to assessing the situation. Because if it was as simple as a single metric or with a single number, that would be straightforward. But it clearly isn't, because of all the factors we've considered. But I think it does come back to what we can and should be doing now, because Plan B is a sort of what might be needed, but I think we are seeing everything going in the right direction in terms of take-up of vaccination, particularly the booster campaign, but also going back to the first vaccination, which I know Professor Pollard and Professor Holgate have described as being really key, and the communications around that, both for older age groups and younger. So, and I share the view that we should all be wearing face coverings where we can, in trains and tubes and crowded spaces where it makes sense and is already part of the recommendations. As all of us have described, the next step up, which has impacts much more widely on the economy, needs to be taken both on a more with science advice informing policy rather than on a single number.
Okay, that's very helpful. And one final question. SPI-M, as I'm sure you're aware, set out a statement in September that stated that if enacted early enough, a relatively light set of measures could be sufficient to curb sustained growth. During a period of sustained epidemic growth, however, the more stringent the measures introduced, the shorter the duration needed for the measures to be in place to reduce to a given prevalence. Do you think there is a risk that if we don't enact parts of Plan B now, we are looking at more sustained periods of more stringent measures in the future? And the same question to everybody on the panel, starting with Mr. Stephen.
I do, yes. I mean, I can't speak on behalf of the Academy now because all of this wasn't obviously available then, but I'm speaking as a respiratory physician on the front line in Southampton. And the answer to your question is yes, I do.
Thank you. Professor Chappell.
I think it suggests that Plan A and Plan B and whatever the Plan C looks like are sort of mutually exclusive, but they're not. There is overlapping, for example, in use of face coverings, and we do not have to wait for a trigger. I completely accept Professor Holgate's point about the communication of it and asking both individuals to think about the risk and think about how they can protect themselves and others. So we don't have to wait for a trigger to enact sensible behaviours that will reduce it. And so it's a question of how we ensure that that message is communicated. It is a real strength that we now have much more transparent data. People can follow that. But there may be a point where ministers do make that decision. And that will is being constantly assessed both by SAGE and by the ministers.
Dr. Wade.
So SAGE have been very consistent in this advice that the earlier you act, the greater the impact of any intervention. At the same time, I think, as the September statement, SPI-M undertook a very useful review of what has happened over the summer, the disease trends, and of course we're very much at the lower end of some of their July models in terms of the number of cases. What we really learn from the summer is that it takes fairly small shocks or nudges, either up or down, to push R and thus the growth rate above 1 or below 1. So you're either in a growth phase or a shrinking phase. That's quite reassuring in a sense because fairly small steps that we can all take, making sure you meet outside where you can or in a well-ventilated place, wearing a mask, keeping your distance, good hygiene and so on, will help push things into either a slow downward phase or mitigate a slow upward phase. The point there, though, of course, is that would be a fairly slow downward pressure rather than some of the very sudden drops we've seen around the larger, more impactful, but very, very costly interventions of the last 12 months.
Thank you.
Thank you, Rebecca. Professor Chappell, is there a Plan C?
It has been proposed, the name has been mentioned. It is not being extensively worked up. Tom may know more from the UK Health Security Agency. People have used the phrase, but it doesn't.
In the Department of Health, is there a set of measures beyond Plan B that is being put together?
At the moment, the focus is on Plan B.
Is the one that's being prepared beyond Plan B?
I haven't been consulted on anything about a Plan C, no.
You don't know anything about that, Professor? Okay, thank you. Catherine Fletcher.
Thank you, Chair. I just wanted to return. I want to talk about variants. Basically, we need public permission at this stage to engage in anything. And it strikes me that we need to give the public information and data to gain that permission. Because we have, for the last 18 months now, basically been having a massive impact on lives and livelihoods. You know, the British public have been marvellous. We've heard evidence at this committee how they have engaged in life-changing, literally, measures for months when the expectation wasn't that would be the case. But I certainly sense there is a subset of people that quite frankly have had enough of doing that. I think it was probably visible on your train on the way in. You know, if I stick a mask on, I had COVID for the second time, I've been double jabbed, it's really unpleasant, so I will stick a mask on. But I can get tutted at for virtue signalling about using the mask. So I'm going to be deliberately challenging about the things that might give the British public the information they need to kind of change those thoughts and views. And one of those is actual data. So if I may, Chair, I'm going to pick up the thread that you started with, which is normal people will say, everybody that's in intensive care has not been vaccinated. The vaccine is available to them. There is an element of personal responsibility to that. To be clear, not my view, but one that has been expressed to me. And that this gap between people dying of COVID and people dying with COVID is being used as a slight justification by some people. So before I come to the other part of it, Dr. Waite, there's got to be a middle ground between every 3-month ONS data and the daily kind of quick and dirty data that gets put together by the NHS to give us an emerging trends. I noticed you answered the chair, but can we just return to that? Because if we're going to start asking people to do something that they are resistant to, the first thing we will need to do is say why and in numbers.
Agreed, and I think there is, and I may be wrong, it may be a monthly update from the ONS, but I certainly know that it's a routine publication. I think the middle grounds that you might be talking about is not necessarily going to the absolute extreme end, which is mortality from coronavirus, but as you said, the admissions to ICU, the admissions to hospital, as those can be very life-changing for people, particularly people who may already be unwell, but even in your 20s or 30s, being admitted to hospital, being admitted to intensive care, it can be a long, slow road to recovery after that. Those figures certainly are put together every day and published. I think the important way perhaps of getting to that hearts and minds piece that you were talking about is then trying to explain for any given age group what the reduction in their risk is from being vaccinated, because it's not the same as you go through the age groups.
Yeah, forgive me. I mean, we're talking about the almost immediate imposition of a set of measures that some people find unpleasant, face masks and trains, for example. So it's not the vaccination debate, it's the debate about how do we take the British public with you on the recommended advice. So I think vaccination is important but separate.
Raw numbers on the number of people who've been admitted to hospital, for example, are published every week by PHE. They publish that in there. I think it's called a vaccine surveillance report, but it gives you, in a given age group, I think I have them here somewhere, the number of hospital admissions in an age group, and then of those, how many are double vaccinated, how many are unvaccinated, and you can make comparisons between them.
Yeah, but it's not dying of COVID versus dying with COVID or long-term effects of COVID that I'm aware of.
So I think just to drill down a little more on the dying with COVID, quite often having COVID will be the precipitant for your heart attack. It is a significant contributor, or to your superadded pneumonia. I don't know if Lucy wants to say more about those. So yes, it is a part of your admission, but that's no different from many other infectious diseases. Take flu, for example. A large number of people who come into hospital any year, really, apart from last year, they may have flu as one respiratory infection, but a pneumonia on top of that can be what, unfortunately, can be the sort of the final straw if you take that analogy.
I completely accept that, but in a normal flu year, we're not asking people to do stuff they don't want to do that they perceive to be injurious to their lives and livelihoods, be it changing the way their businesses operate, be it changing their personal habits. I don't understand why we couldn't create a publicly accessible data set which allows for this interrogation and maybe some myth busting.
I think...
Sorry, Professor Chappell, yeah.
So I think it's not a binary death from COVID versus others, because there's a leading cause of death on a death certificate and there are contributory. But, I mean, for example, I've got the September stats here. So dementia is the leading cause of death. Ischemic heart disease is the second cause of death, and COVID is the third. Other similar levels are lung cancer, cerebrovascular disease, chronic lower respiratory disease. But the extent to which COVID is contributory will be varied across those for all the reasons we've heard. So I think I share your views on publishing data where possible, but sometimes it is easy to present it as a all or nothing when it isn't. And for those who are in hospital, and we've all got experience of this as doctors, it does matter at one level, but if your relative has died, that the exact leading cause is probably less important than the fact that they've died at this time, and that's what they say to us.
I personally, I'm not arguing with you, but I'm trying to explore a mechanism by which we can have a better debate, because Sir Stephen's just given very clear views where we need to start going back to stuff that a lot of people are resistant to doing, and we've got to find a different way of talking to them. And I think data is, and the uncertainties within data is one route. Jim, I'm a little bit away from my brief, so I appreciate you asking, but maybe it's something we can give further consideration. So I just wanted to come back to the other thing that will be a very strong and powerful trigger for people to do NPIs again, which is either a differential threat, which is the emergence of new diseases or an increased virulence of existing diseases due to waning immunity over lockdown, or new variants. So if we just come back to new variants, we've heard from Dame Sarah Gilbert that she believes it's unlikely that we'll have a full vaccine escape variant. If I go across, can I just confirm whether that view still holds in your mind, Sir Stephen?
Yeah, well, I'm not a virologist, so I'll say that's not. But I mean, we have the AY4.2, which is around now, which also came out of India, incidentally, which is interesting, as the Delta did. So it's just a branch of that Delta virus. And it's, said to be 10 or 15% more transmissible. But the vaccine is effective against it. I think we've been concentrating very much on the spike protein, on the virus, which is its way of getting into cells. What this virus has done is to learn how to avoid what we call the innate immune response, which we haven't talked about at all. We keep talking about the adaptive immune response, which is all about vaccines. The innate immune response is why children are not getting disease, why older people, obese people, people with diabetes, why they're getting disease, because they do not have that initial ability to eliminate the virus when it first comes in. And it comes back again to fomite versus aerosol, because the reason why the aerosol is so damaging is that it gets to the parts of the lung where fomite wouldn't get. It penetrates, and that's why it's more severe. So I think the important thing here is to think about variation, not just in terms of a single group of proteins that everybody's focused on at the moment, which is the way the virus gets into the cell, but all those other proteins which can confer upon a virus an ability to get round the immune response. And so far, there haven't been any, in those other multiple proteins. But it doesn't mean they're not going to be, and that's the point, really. I think, we can only go so far in predicting from what's happened in the past and try to learn from other viruses. But, I would not be at all surprised if somewhere in the world another variant turns up.
Forgive me, I'll do the follow-up right there. Do you think we've done so well with vaccines, we're creating a massive selection pressure?
Yeah, exactly.
Yeah.
I mean, that was the next thing I was going to say. By generating these highly effective vaccines, which is super, and we keep talking about them, you have actually put a selection pressure on a Darwinian system. And although viruses aren't really truly living things in the way we think about life, they are mechanically able to mutate randomly until they get round an
volume
obstruction.
game, and they've got the volume.
Correct.
Yeah.
So, I mean, I'm not saying it will happen, but I think to say that it won't happen, I think is really quite a bold thing to say.
Just on that point, if I may, because it's a fascinating important point. So, Dame Sarah Gilbert, on this point, she takes, I guess, a more optimistic view. She says that if the virus changes its spike protein so much that it can't interact with the ACE2 receptor on the surface of the human cell, then it's not going to be able to get inside the cell, which leads her to conclude she doesn't think there's an enormous amount of concern that we're going to see a switch to something that evades existing immunity.
And that's all about the spike protein. But what about the mutations in the other 75 proteins, which aren't the spike protein, which confer the ability of this virus to evade the human immune response?
So you are more worried than Sarah,
the spike protein I think is fine, and everybody's concentrated on that as if that is the only way the virus is able to mutate. But what this virus has done in the bats and other animals it's been in is develop mutations and changes that has enabled it to live in these animals, like bats, fruit bats, without causing disease. But it's only when it gets out of those particular animals and into the human that our immune response isn't able to cope with that. And if this virus starts to learn some tricks to get round the vaccine and the other immune responses that we might be able to generate, then there could be issues. And I think it's quite difficult to know in this random mutation world, which is what's happening here, how a pressure selection might actually confer an advantage on the virus to get it round. So I'm only saying that because I'm talking now as a respiratory, not as a vaccinologist.
That is why it's a particular privilege to have you with both hats on.
Yeah, it's very easy to enter into the science of it, and I'm continually wheeling myself back to it could happen, but people don't want to wear masks on trains because of a could. That's the basic trade-off that we have. May I ask, has any of the modelling for this winter are you modelling for potential new variants and a need for a completely novel vaccine, or?
There's two aspects to it. One is the modelling, which can make assumptions with and without a variant, and the other is what infrastructure have we got that will help us. So some of the infrastructure was here before the pandemic, so the UK Vaccines Network, which allowed us to be well ahead of the game in terms of stepping up, as you've heard, on the Oxford-AstraZeneca vaccine. And then the other sort of component of this is the genomic sequencing that is going on and the extensive networking through the WHO and others to understand what is going on with variants, and the very intensive daily work that is done on assessing the risk of those variants, which is why they may move to a variant under investigation or a variant of concern. So there will be a range of opinions, and it possibly matters, they may all be right or wrong, but what matters is, are we watching out for it? And I think the surveillance that we have in place through the UK Health Security Agency and other mechanisms, and through the more international look, means that we are as well, but certainly better placed than we have been. And I guess there is a real move within government to think about the 100-day mission, so the bigger pandemic preparedness, which will be off the sort of through the rest of this pandemic, but also in preparation for others.
Yeah, fair enough. Thank you. Dr. Waite, just to draw that one in.
I'll try to sort of step out a little bit to sort of population health rather than the virology. But there are three key aspects with variants. There's almost a triangle of things that can alter their effect or their impact on the population. You mentioned one, which is whether or not a new variant escapes the vaccine. The second is whether or not it is more transmissible. And then the third is whether or not it causes greater or less disease than other variants. And we've seen some variants already emerge which have had a degree of vaccine escape. Beta, I think everybody will remember, emerging quite some months ago now. However, if it can't compete with more transmissible variants that are already in circulation, Delta being the big one at the moment, it's just got sharper elbows. It pushes that more vaccine escaping but less competitive vaccine off variant off the pitch, which is important to sort of think about in terms of the global burden of disease, because Delta really has pushed a lot of things out of the way at the moment because it's more transmissible. Those three aspects sort of affect one another. And I think just the other point on vaccine pressure, historically we've managed to reduce the burden of a great number of diseases through very successful vaccination programs. I don't see any reason to think that this would be different.
Yeah, that's a very fair point. That's a very fair point. So, if I was to summarise, please tell me if that's not the case. If you've not had a jab, get a jab because you're really at risk. But if you can, please, start to think about reducing transmission just while we're in the run-up to winter, just while we're assessing some of the other things that are going on.
If I might add to that, many of the people we vaccinated on Saturday at my clinic were having their flu jab and their COVID jab at the same time. That's really important for this winter.
Really good point. Thank you, Chair.
Thank you, Catherine. And just finally for me, kind of reflecting on where we are looking into the winter, most years the NHS faces winter pressures. It's never easy running the NHS during the winter. The latest figures, or the figures for the middle of October, of people in hospital with COVID were about just over 7,000 patients with COVID, which is about 11 per parliamentary constituency. And some of those, as we've established, will have COVID, but it's not the reason that they're in hospital. Is there a danger that as we go into the winter, with the pressures on the NHS, that having uniquely the tools available in the Coronavirus Act to be able to impose restrictions on people's behaviour, measures such as advising people to work from home, we reach for them because they're available when the contribution that COVID might be making this winter is significant, but no more than, say, flu in a bad flu year would make, or some other disease in another year. Are we being rigorous in not reaching for measures that may be helpful, but we wouldn't have introduced this winter were it not for having done so before? Perhaps Professor Chabal?
So I think you described the tension between considering the COVID-only piece and considering the wider, not just the direct but the indirect effects, both at an individual level and at a population level. And there is considerable amount of work across Department of Health and Social Care to consider the wider impacts and not to see it just as an isolated problem. So that will range from the work being done to tackle the backlog, and to look at elective recovery, to look at increasing work on the diagnostic strategy to increase availability through the diagnostic hubs and other routes, to look at how we also achieve earlier, for example, work towards earlier cancer diagnosis, to look at where the impact is greatest of the indirect effects of COVID, so where we want most catch-up, for example, in diagnosis of hypertension. So you're right that at this stage we are very much moving to a place where we are trying not to consider it just on its own. We have got additional measures that are both available and may or may not be enacted as policy, but there is, across the Department of Health and Social Care, there is a very clear view that it needs to be considered with the direct and indirect effects as a whole, not in isolation.
And in a previous session, I think last autumn, we discussed the impact of the government scientific advisors warning the government that the NHS was going to be overrun. That is a very powerful trigger. It's very difficult practically to gainsay that. Is there a sense within the Department of Health, perhaps you, Professor Chabal, as the Chief Scientific Advisor, and you, Dr. Wade, as the Deputy CMO, of just the degree of responsibility that needs to be exercised in making an argument that the NHS will be overstretched, because that is a use of a card that is very difficult, as I say, to gainsay. Is there a sense of just how important that is?
I think it is a strength of the approach by Sir Patrick Vallance and others that scientific advice is now more tapped into than ever before, both through the network of chief scientific advisors and others, and calling on multiple groups through SAGE and many other committees, whether it's NERVTAG or JCVI, and we've really seen that come to the fore. So we've seen more clear use of scientific advice and more transparency about those decisions than ever before. So I think we should really welcome that input. SAGE can, the transparency with which SAGE provides advice and provides and publishes is clear, but I think we should recognise that the scientific advice is one component, and the societal response and the responsibility of the elected politicians to make those final policy decisions is also clear. So I think there's space for both, and I think that we continue to do that now as before.
I think certainly in the conversations I have, what there is the greatest awareness of what we mean by NHS pressure. That is people who are waiting to be admitted to A&E. It's people who are going into hospital because they are ill for any number of reasons, and that's very much at the forefront of an enormous number of conversations, and one of the reasons that monitoring not just coronavirus admissions, but all the other respiratory infections this winter, all of the non-communicable disease admissions to hospital, emergency and elective, is really, really important. And therefore, not just looking at a single metric, so hospital admissions, but thinking what's the entire pressure on the system. People will wait for ambulances, people will wait for discharges and so on, and seeing the NHS as a sign that people are unwell and requiring hospital treatment rather than seeing it as a service to be protected. It is a service that is there and is busy because people are unwell, and that's very, very important to remember.
Thank you very much indeed. Perhaps I can thank you all, Sir Stephen, Professor Chappell and Dr. Waite, for giving us the benefit of your expertise and your practice. We're very grateful for your evidence to the committee today. That concludes this session of the committee. Order.
Thanks, Chris.
Thanks very much.
Thank you very much.
Thank you for your time.
Rimmond Room. Portcullis House, the Grimmond Room. Portcullis House, the Grimmond Room. Portcullis House, the Grimmond Room.